रहने दो ये वीडियो, अभी स्टार्ट ही कर रहे हैं, इसको इन बिटवीन चला देंगे। ये इन बिटवीन जैसे लंच वंच टाइम पे होगा ना फिर चला देंगे।
नो इशू, ये वाली सर वीडियो मुझे सेंड करवा दो, मैं अंदर से ऑपरेट करूँगा।
अब यहाँ मुश्किल अभी अभी रुको, अभी मेरे को स्टार्ट करने दें। May I request all the delegates to please be on the seats. We are just about to begin. Sir, please. Mehak, Bandana, can you just request all the people to be on the seats? So I, Rajesh Sharma, Chief Administrative Officer of NHS, have the grand opportunity of welcoming you all to this historical but very vibrant and young city of Jalandhar. So in fact, NHS Hospital is also as young. It is just 6 years we are into NHS Hospital. But within 6 years, in a short span of time, we have done a lot of work in academics and a lot of new technologies in the medical field as well as surgical fields are brought into this region by NHS Hospital. And also we have the tradition of conducting this kind of academic exercises almost every year in different fields. And under the guidance of Dr. Shubhang Agarwal, who is the director and HOD of orthopedics department of NHS Hospital, we have got a lot of new things here in this hospital, and we were among the few in the country to start with robotic surgeries. And along with that, we had the pioneering effort in a lot of orthopedic surgeries innovations also, like the leadership position in sclerosis, the advanced traumatic reconstruction surgeries, pediatric orthopedics, knee replacement, hip replacement, all in robotics. So these are the major achievement of this department of NHS Hospital in this region. And in the
matter of triple joy for me. First, for the delegates who are slowly trickling in, it is a matter of privilege to have heard during the day from all the stalwarts who have been so great in their faculties and in their orthopedic procedure things. And I remember that when I did my MCH neurosurgery some 25 years back, today practically 90% of my surgeries are not what I saw during those days. So there was one very hit movie which said entertainment, entertainment, entertainment. And now what I would say in a CME, the three words that should be upgradation, upgradation, and upgradation. For the delegates, it is a matter where they can upgrade their skills and knowledge. In terms of NHS, very briefly I would want to introduce that in 2018 when we started this venture, we started with a vision to bring a difference in the healthcare. And our tagline and the motto at that time was to bring in the best of the technologies with the experience so that we can deliver good results. And in addition, we have been involved in the program of leadership in Leeds and Duke's University in US. We have been known for bringing in newer technologies in all the fields, in the clinical fields that we have here. Like Mr. Rajesh just said that we are probably the first in North India to have 2 separate robots for different types of surgeries in orthopedics. Similarly, in all departments, like if I talk about neurosurgery, we have got all the technology, including the navigation and everything that is required for neurosurgery in our hospital. And everything that is required for neurosurgery in our hospital. The support services like MRI, CT, they are all high-end and upgraded so that we do not compromise on the results of the patients. Recently, we have been leaders in North India for bringing in innovation in technologies. Like we have been mentors and associated with IIT Bombay, IIT Gandhinagar and IIM Mangalore for different healthcare startups so that we can introduce newer technologies, newer innovative technologies in healthcare. Last but not the least, it is a matter of joy that probably in our endeavor to bring in the teaching streams and the academic fees to NHS, we are planning to start, we have already started with critical care medicine in emergency services in NHS, and we are in the process of starting DNB programs in different streams in NHS. And it is a privilege that for the first time probably in this part of the country, in association with Indian Orthopedic Association, Indian Arthroplastic Society and Punjab Orthopedic Association, along with NHS, this type of workshop has been created. So I welcome everyone who has traveled so far in this early Sunday morning to this part of the country for this wonderful delight of feast, that academic feast that we are going to host in the next couple of hours. Thank you very much.
Thanks a lot, Dr. Chitkara. Then we are very thankful to Indian Orthoplasty Association who has given us this opportunity of holding this live surgery workshop today. We have the message from Dr. Ronan Noy, who wanted to be present here, but because of certain family engagements, he couldn't be present with us. He has sent us a video message. Can we just play that?
Delegates. I would like to wish all the delegates coming to Jalandhar for this wonderful meeting a warm welcome on behalf of the Indian Arthroplasty Association. I'd also like to say sorry that I'm unable to make it there today because of family commitments, but I'm really happy that Dr. Shubham Agarwal and his team have managed to put this fabulous program together for all of you. I'd like to thank him and his entire team for their efforts. And I'd also like to thank the entire faculty for taking the time out for making this wonderful event possible. I wish the event a grand success, and I would very much appreciate if you could submit some basic feedback to Dr. Agarwal so that we could try and make this program even better in the future. I wish you all the very best for the morning and the day ahead. Good day.
Can we have a round of applause for Dr. Ronan Roy? And we are also thankful to Dr. Nader sir, who is the Secretary of Indian Arthroplasty Association, for giving us the opportunity to hold this conference. So here comes the first live session of the day. This is by Dr. Nilesh Shah on total knee replacement surveillance approach. So may I request the moderators of this session to be on the dais, please. May I request Dr. Hariom Agarwal, Dr. Sudhir Garg, Dr. Manoj Vadwa, Dr. Sanjeev Mahajan, and Colonel Jafar. Can you be on the dais, please, sir? In case somebody want to ask the question from audience to the surgeons in the OT, we have two-way communication working. So we have the person who will bring the mic to you, so you can ask the questions to the moderators and they will interact with the surgeons there. I extend you a very warm welcome, sir.
Thank you very much. First of all, I congratulate Dr. Shubham Agarwal for taking such a great initiative for the live arthroplasty workshop today. And it's even a great pleasure, and I think all the delegates will be fortunate enough to see the stalwart of the knee arthroplasty, Dr. Nilen Shah, operating today in front of you. And I think Dr. Nilen is already ready with the knife to show the skills which he performs for the best outcome of the patient. Just for the knowledge of the delegates, that today Dr. Nilen Shah is going to show us the total knee replacement by sub-vastus approach. There are different approaches for this technique. So,
एक जगह मॉक दे सर मॉक दे मॉक ये मेरे को ना बहुत से मॉक्स करने हैं सर्जरी में भी अगर ज़्यादा मॉक्स करेंगे पहले साइलेंट का यूज़ है ठीक है ना आपने जो है वो
Okay, so have you seen your Are we audible in the audience?
Yes, Dr. Shubhang.
Okay, so we are going to, David is getting ready, Dr. Nilen Shah, and he is just telling about the first case today. This is a 70-year-old lady who needs for, we are going to do the right knee for her today. The approach taken will be a sub-vastus approach, and there are some special things that Dr. Nilen Shah will have to do. So she's got range of movement from 0 to 3 of 50 and getting whereas to form. That we see here, and that also actually means towards the right one, and so because that more pain.
Dr. Subhan,
You can see on the screen.
Dr. Subhan, are you able to hear me? The X-ray picture is not clearly visible to the delegates.
Sorry, you can't see the X-ray? It's not it for
The pictures are looking very bright.
Right.
Good morning.
we can hear you now.
Better than previous.
Hello. Dr. Hariom, is that Dr. Hariom?
Relatively better. Please go ahead.
Okay, चलेगा अच्छा या
Dr. Shubhang,
Yes, can you hear us?
yes, he can hear, it's not focused. Yes, that's, आपको एक भी, Dr. Shubhang is be focusing on one of those three, maybe on the, the scanogram.
One scanogram.
Yes, that's much better. Yes, please.
Yeah, it's good.
Yes.
now?
Yes, perfectly, we can see it now.
Okay.
Good morning.
Dr. Nilesh Shah.
Good morning, Dr. Nilen.
Good morning.
Sir,
Good morning, Jalandhar.
Good morning, Dr. Nilen. Please, we can see.
Thanks a lot for giving me this opportunity. And I thank IIM and Shubham in particular. Can I see the knee?
Yes,
Can the knee be seen?
yes, Dr. Nilen. Can we reduce the brightness a bit, please?
So on the whole, it's a straightforward knee.
And volume is also very high.
Can you hear me? You want me to start?
Yes, please. The picture is very...
Start.
Dr. Subhang, please reduce the intensity of the brightness.
So reduce the intensity of the brightness. I am Nitish here to help you with the surgery. The patient is painted in gray. This is the patella.
Yeah.
Okay? So I'm making an incision. Can you all see?
Yes, sir. Yes, sir.
So there is no tourniquet.
So you have not applied any tourniquet, and
Sorry?
no tourniquet have been applied, and you have given the midline skin incision.
So on the whole, it is a straight incision based on the patella.
Sir, which approach you are going to follow?
Sorry, I could make out.
For the delegates. Yes, for the delegates.
I'm going to use the subclasses approach. So what is important is that you expose the quadriceps, see the fascia, and then infiltrate a little bit more. So I call this hydrodissection. Now having done that, you just peel off the fascia from the muscle. Can you all see this?
With the adrenaline?
Yeah, normal saline, little bit of adrenaline and hylates. So this incision is made in flexion, and then you extend the knee.
Sir, Dr. Subhang, kindly reduce the brightness.
And then you can see the muscle quite clearly. Can you see the muscle?
Sir, everything is looking bright, white. Nothing is visible to the delegates. Brightness is, I think, too much.
Nothing is visible to the delegates.
Brightness is too much.
ये actually light कम कर दो.
Light,
मीटर का light कम कर दो. ये सराय.
Sir, it is better now.
You can see it now.
Better.
मत रख, तो भी चलेगा. Can you all see now?
Yes, sir. It's relatively better. Sir,
Light निकालिए चलेगा.
just for the sir, delegates, we know the advantages of infiltration of the software.
The crux of the subclasses approach is going to be done now. So if you are, can you all see or not? Because in 2 minutes it will be done.
Yeah. Sir,
Can you all see? Shall I proceed?
नहीं सर दिख नहीं रहा प्रॉपर. It's not properly visible.
जरा मंगा के रख. Yeah. I'll wait.
Sir, just for the delegates, share for advantage of the sub-doctors approach over the conventional middle parapatellar approach. Dr. Nilen,
Dr. Milan sir, can you hear me?
ये साइड में ले ले ये करा ये आगे ले ले
Sir, it's better.
लिफ्ट का जितना ऊपर लाता है ऊपर लाता
It's a better now, but still the brightness is there, especially in the thigh region. Yeah, sir, now it's very clear. Dr. Miller,
Can it be seen? Quadriceps muscle.
yeah, sir, yeah.
Shall I proceed?
Sir, please go ahead. Sir, just for the delegate, sir, can you share the advantages of the sub-doctor's approach over the conventional medial parapteral approach?
So now what I am doing is, I am elevating the quadriceps from the fascia. And with my finger, I can feel the femur. And this is the proximal part of the subvastus approach is done. Can I have a right angle, please? नहीं, right angle retractor. ये दोनों निकाल दो. One more right angle, please. इधर again. Can the table go up a bit? So can it be seen now?
Yes, sir, it's visible.
Table zero ऊपर लेना. Now can everything be seen?
Yes.
This is the patella. Yeah. What I am moving, the muscle, the whole quadriceps has been taken to the lateral side by this retractor. This is the attachment to the patella, vastus medialis and obliquus. This is the patella, this is the patella tendon. Can it be seen?
Yes, sir.
Yeah? So now what we do is that the distal extent, it's going to bleed a little bit, there is no tunicate. Huh? So don't be afraid of some blood.
Sir, have you
Distal
taken,
extent,
sir, has the,
same as the parapatellar approach, and this is the proximal extent. So now I am on the suprapatellar pouch, which I have divided, and this I have divided. Suction नीचे करो. So the subvastus approach is done. निकालो. So after having done this, we flex the knee a bit. Focus है ना? Can it be seen?
yes, sir, it's visible. Sir, as you have not applied the tourniquet, what precautions you have taken?
So I am removing the hypertrophic or rather the infrapatellar fat pad.
Electronexic acid दिया हुआ ना इन्होंने.
Can we raise the table a bit, please? This is the ACL which I have just incised. This is the anterior horn of the medial meniscus. And I am raising the medial periosteal sleeve.
Fully revert नहीं करनी
Can I get a periosteal elevator,
तो
please?
laterally लेके ना इसमें का blood हो जाता है ना पूरे
Dr. Hariom, if you speak, please take the mic closer.
So we raise the medial periosteal sleeve in this direction. Now there is a lot of talk about release and not to release, but my standard approach will consist of putting the limb in a figure of position like this putting this right angle spike, taking care of the meniscus like this. Can it be seen? Forceps.
Yes, sir, it's visible.
Forceps. Tooth forceps.
Sir, beforehand, have you given tranexamic acid also?
And I will release it like this. So this is the standard approach, and it is done. So now, what we can see is that the deformity of the knee is fully correctable, and we can proceed with the surgery. I generally prefer to do a cruciate retaining knee. Small osteotomy. So this is a Punjabi hammer, like a lassi ka glass. So I prefer to use a small mallet for this.
Sir, any tip for the entry point?
Midlers, please.
Sir, where you make the femoral entry point?
So the entry point is just above the PCL. Midlers again. Starter जैसा है. Starter है चलता है इधर instrument आ जाता है. Drill वाला starter.
Sir, this is right in the midline or slightly middle?
Midlers, please. Jig, please. So this is the distal cutting jig. So you're going to put this. Punch जैसा इसको ठोकने को दे देना. Now we have to extend the knee a little bit. Center में फिट डालूंगा. तो फिर center में डालूंगा. Put it in the center. Center. Put the other pin also.
Dr. Shubham, focus has been lost. Focus on. Yes, that's better.
Dr. Subhang, are you able to hear us?
So invariably when we put this pin, it tends to cut a little more. So I'm going to do -2 here.
Nilen, you don't evert the petla. Dr. Nilen, you don't evert the petla.
Table touch down, पकड़ के रखो. ये पटेल प्रोटेक्ट करना.
Dr. Nilen, sir.
Dr. Nilen,
Is anybody there?
Sir, can you hear us? Dr. Nilen, sir.
This is the boundary of the osteophytes. We tend to remove that also.
With the OT, we have to speak slightly louder. That is what they are saying.
Okay.
Yeah, hold the mic close and.
Okay.
Not able to.
So now we extend the knee and see whether the cut has been adequate. So the cut looks fairly adequate. Right hand spine.
Hello, Dr. Nilen, can you hear us?
Right angle spine.
Dr. Manan sir, can you hear us?
Dr. Nilen, can you hear us?
So this I am just cleaning the tibia a little bit.
Dr. Nilen, can you hear us?
I can hear you. So now having done this,
Dr. Nilen, one question.
yes,
How do you retract the patella? Because with subvastus you
I
might.
will come to that.
Thank you.
You will be able to see patella resurfacing also through this. Can you all see the whole distal femur clearly?
Yeah, we can see now.
So very often I just put this put the trial femur like this, and this looks like the right size, but we have the option of narrow also. So maybe 5 also. 5 narrow है तेरे पास?
Anything specific about the MyTech anchor, or can we use any other anchor?
In the MCL damaged, we have a series of such patients, which I'm sure Rakesh and Dr. Sen has seen in many times in my talks. The augmentation of the MCL or the reconstruction of the MCL is possible. So if you have a partially damaged MCL, use an anchor 5 millimeter or 6 millimeter anchor and suture it back and give a plaster for some time.
So my question is, you said the MyTech anchor.
Right.
So anything specific about that anchor or the technique, or you can use any anchor?
Any anchor which attaches the damaged portion of the ligament to the bone is what is important, right?
Can we have the next speaker, Colonel Zafar, on the dais, please? Big round of applause for him. He's from Jalandhar itself. So, can we have the applause? Why is missing for the our own people?
Hello, good morning, ladies and gentlemen. Topic for me is bone defects on tibial side in a primary TKR. Okay, so it's very common in revision scenario, but since we are doing in this complex primary TKRs, it is fairly common. So there is variability in the size and location of tibial defects, and the pathology is bone erosion, consequent to the overload of medial or lateral compartment and followed by collapse of the subchondral bone. There are multiple methods to fill this defect, and our aim is to have proper tibial component positioning, joint balancing, stable and lasting fixation. So initially we used to have this uncontained and contained defect. Rand used to classify them, and we have been following this. So next, more comprehensive classifications is AORI, Anderson Orthopedic Research Institute. Type 1 is in which minor bone defects with intact metaphyseal bone that does not compromise stability. Treatment is cement fill and impaction bone grafting. Coming to type 2A, when we have metaphyseal bone damage involving tibial plateau of on one side, and 2B when both the sides. Treatment again is cement fill, augment, small bone graft, and a revision stem to offload the construct. AORI type 3 is a revision scenario in which there is massive bone loss, a large portion of the condyle plateau is involved, and collateral ligaments and patellar tendon can also be involved. So treatment here would be bulk allografts, custom implants, mega prosthesis, porous tantalum, metaphyseal sleeves, rotating hinge, which we are not talking today. So coming to location, so peripheral posteromedial defect is common in varus knees, and contained lateral compartment defect in valgus knees. So the chronic situation and underlying bone osteopenia is the cause. Others which have been implicated are chronic ACL deficiency, osteonecrosis, bone cyst, trauma, previous osteotomy, and inflammatory arthropathies. So management options, we start with the first one, which is the easiest one, is to downsize and lateralize, translate the prosthetic component away from the defect. So downsize and lateralize, use the tibial spacer to reduce the size of the defect, avoid tibial resection as deeper tibial resection, as there will be poor quality metaphyseal bone there. Also there will be chances to injure the soft tissue attachments, and we have to keep the joint line preserved. So type 1 contained defects, using only the cement. This, if defect is contained defect and 5 mm or up to 10 mm. So Ritter and Dorr have published that if the defects are less than 5 mm and contained defect, then cement alone is enough. For peripheral bone defect, less than 50% area, less than 5 mm is okay. In 2012, Fosco have published that it is enough. And the strength is comparable to morselized bone grafts and metal augments. For type 1 peripheral defects, size 5 mm to 10 mm, and contained or uncontained, cement and screw is good. So you can use 4.5 or 6.5 screws embedded in the cement, 5 to 10 mm apart. The screws will reinforce the cement and distribute the load away from the joint line and the cement bone interface. Screw heads are placed 1 mm lower than the tibial implant. So AORI type 2, in which the defect is more than 50% of the tibial surface, so we should think of bone grafting. So the host bone has to be freshened. The bone graft size has to be from 0.5 mm to 1 mm. Size less than 0.5 mm gets absorbed in the inflammatory process. Size greater than 1 mm is slow to incorporate. And cancellous bone graft remodels is what we want to achieve. So Windsor et al. Have shown this technique in which distal femur bone cuts, other cuts can be used and reappropriated, fixed, so that we can take care of the uncontained bone defects. The aim is to restore the joint line, and we have to be sure that the cement does not intrude into the graft host interface. However, if the defects are bigger, greater than 3 centimeter, they may require structural allograft. So in such scenario, we'll have to use tibial tuberosity as the reference point if we are using intramedullary entry point. If we are using extramedullary, then go as using the extramedullary jig. So defects, an oblique defect has to be converted to a rectangular defect, stepped defect. If we are using allograft, then we have to resize the allograft, fix it with temporary K-wires, go ahead with the tibial preparation, serial reaming for the tibial stem, finish the tibial preparation, fix definitive screws, use stem tibial implants, and do trialing. The K-wires can be changed to screws, and final situation. So structural bone allografts, advantages, it restores the bone stock, it is biocompatible, cost effective, allows custom reshaping. There is possibility for ligament reattachment, but due to in Indian scenario, it is difficult to get allografts. Tigani et al. Have shown that 5-year follow-up, there were no acute or chronic complications. Graft host bone incorporation was good. There was no prosthetic loosening, no radiolucent lines. Survivability of autogenous bone graft. There's a classic paper by Dorr and Ranawat, which they have published in 2006. And they have shown that 22 out of the 24 cases had good graft incorporation. There was no tibial collapse. And the graft choice were distal femur, iliac crest, or femur head. And the time taken was 6 months for the graft incorporation to complete. Okay. Coming to modular metal wedges, used for uncontained defects, size greater than 60% of tibial plateau and depth greater than 1 centimeter. So there's this Korean paper in which they have said that 4-year follow-up, 67 knees, good functional scores have improved, but 10% they had radiolucent lines. However, they said there was no progression of these lines, and there was no difference between 5 mm or 8 mm wedges. So size, there are different wedges, different companies make it. We have to use intramedullary stems when we are using thicker wedges. And addition of stem allows for proper component positioning, enhances the fixation, decreases stress at the bone implant interface. And there's another study, a Japanese study, in which they have compared 33 knees in which they have used metal wedges with 132 varus knees. And they have said that there is no difference in implant survival rates, no difference in knee function scores. However, with metal wedges, there is a radiolucent line in 30% of the cases, and 51% of the cases had rounding of the medial edge of the tibia. So metal wedges have given rise to rectangular blocks. This study by Faring et al. Have shown that metal blocks transmitted better torsional loads as compared to wedges, and multiple blocks can be used if defect is more, but we have to take care that they can be downsized according to the tibial, proximal tibia. Thank you.
Very lucid talk, Doctor. The only one thing that the metal wedges you rightly mentioned, the sclerotic bone when you have in the defect, probably the metal wedges is a good option.
Sir.
But with the reduction tibial osteotomy, probably the use of the wedges or bone graft has itself reduced significantly now.
Sir.
Right. Thank you so much.
Thank you, sir.
Any question you?
Do you use allograft?
No, sir, I told you we have not used allografts. It's just demonstration.
Thank you.
Thanks a lot, Colonel Jaffer. Can we have a big round of applause? We have, because of certain constraints in time and the other things, little change or tweaking of this program. Next, Dr. Prashant Vaidya will be on the dais, and since he has to prepare for his live surgery session after that there will be a little pause for this inauguration ceremony for 4-5 minutes, and the talks continue after that. So, Dr. Vaidya, Dr. Narendra Vaidya, sir. Narendra Vaidya. My apologies, my sincere apologies. Dr. Narendra Vaidya, he has come all the way from Pune. So, can we have a warm welcome like Punjabis to Dr. Vaidya? We heard a lot of big hammers today in the morning, so hands also should be like that, huh? While applauding.
Hello.
क्या कर रहे हैं? सिलेक्ट करना नहीं वही बता रहा था, 1 मिनट मैं करता हूँ. First of all, let me thank Dr. Shubhang Agarwal and his team at Nhs Hospital for inviting me, and IA for organizing such a fantastic live surgery workshop. So today I am going to talk about kinematic balancing. That is now there is a lot of talks we will see for alternative alignment principles. And why is that? That is what I am going to talk. Since 1970s, late 70s, we have all been trained to align the limb with a mechanical straight line, now 0 degrees neutral axis. So that has been practiced for more than 3 decades. So why such a change now? The main reason is that we are putting the knee in the straight alignment irrespective of their native knee structure. So if you see this graph, then you will see hardly 15% of the population has got a native neutral axis, HKA axis. So why put all the other 85% also in the same axis is the basic thought process behind kinematic alignment. This is one classification for the native knee which has been proposed, where the knee has been classified into 9 phenotypes or 9 types, and that is how this generated a lot of interest for the kinematic alignment. So now today, if you see in the world, there are a lot of thought processes like patient-specific alignments like UK, which I will be demonstrating later on today in a live surgery. then kinematic alignment, restricted kinematic alignment, mechanical alignment, and anatomical alignment. So actually these have been tried, but the alternative alignments did not work because the earlier generation of poly and the implants was not as good as today what we have, the better polys and vitamin E polys, etc. And so the wear was more in alternative alignments. So what is wrong in mechanical alignment? So there is a frequent prosthetic overstuffing on the distal femoral condyle. It stretches the lateral retinaculum during flexion. The gaps are frequently tighter than the native knee and makes the limb straight in every patient whose knee was not straight structurally and by birth. So kinematic alignment, it's a relatively new technique. It has been practiced more in last decade. Aims to anatomically position and kinematically align TK components, resurface the knee joint by removing cartilage, bone thickness equivalent to implant thickness. Implants are aligned on the knee kinematic axis around which the patella and tibia will move. We heard the axis, what are the axes in the earlier lecture by Dr. Agarwal. It restores the constitutional knee joint orientation and the physiological knee laxity, especially on the lateral side in flexion extension like we discussed in the live surgical demo. And that's why robotics also play a very important role. Vast majority of the patients are eligible for kinematic alignment. Patients who are less than 50 degrees of deformities, 15 degrees of deformities, relatively supple, partially correctable deformities. And if it is rigid, then we can go for a restricted kinematic or a hybrid approach also. So these are again at the cost of repetition, some things are there where different types of implants, technologies have not solved this 20% of unhappy patients. So this is one attempt, I think, which will go further to satisfy these patients who are actually not happy with their results. So it's more physiological, reproducible implantation, improvement in the knee function, better patient satisfaction, and it is like a true knee surfacing. So these are the three axes. You can see it's a transcondylar axis or cylindrical axis is green, patellar axis in purple, and tibial longitudinal axis in yellow. And the aim is to reconstitute everything. So the typical cut, which will be, you will see the left, the yellow cut, that is kinematically aligned. It will be slightly in varus. And mechanically aligned, you cut less, it's absolutely neutral cut. So the cuts will look different actually in kinematic and mechanical alignment. Even the implantation also will look different. This is how the mechanical alignment is there, which is straight, and kinematic alignment in a varus, constitutional varus knee, initially it will be slightly in varus. So these are, I use always robots since last 6-7 years for doing kinematic alignment. And now more and more patients I am doing kinematic alignment with a window of 5 degrees of residual deformities. So these are a couple of patients. This was a 8-degree varus, partially correctable patient. So this is the implant planning. You can see. I don't know. Which is the pointer here? Yes. So if you can see here, the initial, this is the by default sort of a position given by the robot. And then after that, we have given 2 degrees varus to the femoral component. You can see it is perfectly matching the yellow thing, that is the bone surface. And in the posterior side also it is matching. And the flexion extension gaps, you can see they are perfectly matched under 1 millimeter. So it's a completely balanced sort of a knee. It is important, there was a question asked by the moderator in some time back, whether balance or alignment. So it has to be 100% balance. Balance is very important. That is what we are watching here with robot. There is a absolute evidence that you have got a perfectly balanced knee in this situation. And this is the X-ray. This is the second case, which was a slightly severe case. You can see 17 degrees of varus, which was partially correctable. And this is a scanogram. You can see the gap assessment where medial structures are very tight. This is the initial screen where there is 0 degree neutral alignments. You can see here. And then we have given some degrees of varus. You can see 1 degree, 2 degrees of varus in the femur here, and 1 degree in tibial component. And we have got sub-millimeter sort of balancing here. Once we remove the meniscus, this gets corrected. Doesn't need any ligament release at all. So from 17 degrees varus, we have come to 2 degrees effective varus, and that has given me a completely balanced knee without touching the ligaments. And this is the final X-ray. Sometimes in severe deformities or severe cases, we have to use a hybrid approach. For example, this is a case which has got a combined varus. He has got a periarticular deformity also in tibia. You can see that 16 degrees of deformity just below the tibial tuberosity. In sagittal plane also it is 19 degrees deformity. And so there are three-dimensional deformities. This is a challenging case. It is a rigid varus. There was a talk by Dr. Sharma some time back, and the rigid varus you require a lot of release which has to be judicial. That is what he said. But with robotics, you have got now a tool which can assess what is judicious. It can actually objectively assess and tell us exactly what is to be done. So in this case, we started with 19 degrees varus. On table, slight correction was there. Pre-operatively was 23. Then we have got this neutral sort of placement. Then we have given 2 degrees, 3 degrees of varus in the femur. Generally, my overall this thing is that I go up to 5 degrees of combined varus, not beyond that. And this is post-balancing. You can see from 19 degrees, we went to 3 degrees the achievement, and that is a complete correction without, even releasing much ligaments. So slope is also whatever we planned, we got it. We planned 3 degrees of varus, we achieved 2.7 degrees of varus, and that is how the perfection is achieved with the help of robotics. So what is the evidence now? There are a lot of papers coming up which are showing that the forgotten joint score, then the knee society score are much better in kinematically aligned knees, and so probably in coming time with emerging technologies, we will be using more and more kinematic alignment philosophy. So take home is that kinematic alignment may help in better reproduce physiological knee function. It preserves the soft tissues. Robotics and other technologies will help immensely, and a lot of evidence is gathering for kinematic alignment. Thank you very much.
Thank you, Dr. Vaidya. I think it's a very well explained and difficult topic. Kinematic alignment has been recently been talked about a lot, but we have been seeing most of our population has been in the varus, and the varus has been one of the reasons of the progression of arthritis in younger population as well. So do you suspect that at the moment we have a short-term data for kinematic alignment? Do you suspect that in 10 years time, 20 years time, this thought process may change again? What's your present day feeling?
I think we will go for more and more kinematic alignment and functional for two reasons. Kinematic alignment earlier was tried, but it failed because of the quality of poly and the wear which was there. And the way we were used to cement the prosthesis. Now there are better prosthesis. Even there are kinematically designed prosthesis also, like the Journey 2 prosthesis or medial pivot joints, which have got, designed by itself, it's kinematically designed knee. So I think more and more, and with emerging technologies, I think we will be using more and more this thing. Only thing is that when we are talking of, my apprehension is that we should not go more than 2 degrees maximum varus on the tibia, because I am still concerned about it. So what my, this thing is that combined 5 degrees is what I do. Rotation, I go up to 6-7 degrees also. So, you shape the bone more than releasing the ligaments, you shape up the bone in such a way or sculpture the bone in such a way that your alignment is near to 5 degrees, not beyond 5 degrees.
Very right. One interesting observation, when we were doing the LCS knees 25 years back, and I followed some of my patients for a long time. Now these patients who were left in the varus, they were very happy. What you mentioned, the forgotten joint score, they were very happy, and I think with that, it looks like that kinematic alignment will be the thing in time to come.
Yes.
So my concern is that as we have seen in the chart, like only 15% of the people are mechanically aligned. So let's talk about a patient who is in a constitutional varus of 8 degrees. So what should be your target?
You should not correct it to the full, at least correct it to the half this thing, and keep it in slight this thing.
So is it right to say that when we are seeing a kinematically aligned knee, we are actually talking about a less mechanically aligned knee because we are not going back to the original anatomy of the knee joint.
Yeah, mechanical, I think these are two entirely different principles. Mechanical means 0 degree, but why we should go, for a person who is in 8 degrees of varus, we should not go to 0 degree of the mechanical axis. So you should, without releasing, what is important is your gaps are balanced. So numbers are not very important. That's what I want to say. With the limit of 5 degrees, if your gaps are equal, especially because I am using robot and I have access to the technology, because kinematic alignment with a conventional technique it's very difficult to achieve. How will you measure 2 degrees of rotation, or how will you measure this thing? That is a major block. So some tool, some technology you have to have. Otherwise it is safer to do a mechanical alignment. Because if you want to give 2 degrees to say tibia, with conventional, at least I will not be very much comfortable to do a 2 degree varus cut. Some of the companies have got jigs with varus, this thing, but it's really difficult like that.
Yes, thank you so much.
Thank you.
Thanks a lot, sir. Dr. Narendra Vaidya had a very nice talk. Big round of applause again for him. Thank you. Next, we are going to have the inauguration ceremony. Can I request the people on the dais as chairperson to excuse us for a while? We will continue with this knee talk after a brief inauguration ceremony. And may I request all the delegates who are in the refreshment area or outside to join us inside for this auspicious ceremony. Then may I request Dr. Ramesh Sain, Dr. Narendra Vaidya, Dr. Rajiv Sharma, Dr. Nilen Shah, Dr. Rakesh Rajput. Vanna, kindly escort this chief guest on the dais. Dr. Manoj Vadba, please be on the dais, sir. Then can I request Dr. Shubhang Agarwal, Dr. Naveen Chitkara, Dr. Sandeep Goyal also to join us on the dais. I also have the opportunity of inviting Dr. Rinku Agarwal, Dr. Vibha Chitkara, and Dr. Shali Goyal also to grace the dais with their presence. Okay. And I also take the opportunity of having the presence of Dr. Avtar Singh on the dais. Please join us, sir.
जननी पूजन वंदन ध्यान पूर्ण आदिशक्ति परिक्षमा हमें आदिशक्ति परिक्षमा हमें पूजा के अधिकारी
Can you have the big round of applause again?
This was just to make it quick.
Thanks a lot, sir. Yeah. Can we request the chairperson to be on the dais again to complete our NEET talk session? Dr. Devinder Lal, Dr. Kana Satish, and Dr. Rajiv Sharma. Can you be on the dais, please, sir? Dr. Rajiv Sharma, Colonel Satish, and Dr. Devinder Lal. Dr. Devinder Singh Lal. And I will request Colonel Satish to be on the lecture podium to deliver the lecture on bone loss in female. We had another Colonel talking about the bone loss in tibia. So this other part, bone loss in female, talked by another Colonel. So big round of applause again.
In Australia, most of the revision surgeons have become excellent revision surgeons because they were not so good primary surgeons. So the topic related to me, given to me is bone loss in femur, which is generally not seen in most of the time by the people who are not doing many revision cases. This situation of tibial bone loss is still seen because of various varus deformity, valgus deformity. The tibial bone loss is still seen in some of the primary cases. So, if I may say, this is the most important slide of my lecture, anticipation and preparation. You have to anticipate that in all revision cases, you can have bone loss to the extent where you may require anything and everything. So, go prepared, and you will always underestimate the bone loss which is seen on the X-ray. So, pre-operatively, we are assessing, we are going for a case, you will always underestimate the bone loss which you will find once you open the joint. The causes of bone loss can be osteolysis, septic, aseptic, stress shielding, or it can be mechanical while you are removing the implants which are well fixed. My job has been made easier by Zafar. He has already given you the classification of Anderson Orthopedic Research Institute, which is being followed everywhere. So that 3 kinds of defect can be contained, uncontained, or combined. So type 1 defects are contained where the cortical rim is there. Type 2 defects are uncontained where cortical rim is lost, and type 3 are combined defects. So these are the type 1 defects. Generally, how you assess on X-ray, there will be no subsidence of the components. Osteolysis will not be seen. You can see normal joint line and normal epicondyles. That's how you will assess that there is hardly any bone loss. You can go ahead. And in type 2 defect, there will be some joint line elevation. Means there is some bone loss, some metaphyseal bone loss, and the condylar profile will be reduced. If it is present on one side, it becomes F2A defect. If present on both the femoral condyles, it becomes type B defect. In type 3 defect, there will be extensive metaphyseal bone loss, at which may require some structural bone graft or some special implants. So, what are the goals of treatment for a bone loss? Why we want to replace the bone? Why not replace it with the metal? Because we want to support the implant and we want to restore the joint line, which is best possible by replacing the bone with the bone. But sometimes it's not possible. And also, in order to get a good, strong fixation, as there at least 2-point fixation should be there among the 3 zones: metaphysis, surface, as well as diaphysis. So the solution is, the best solution is replace bone with a bone. If not possible, then there are various other methods which has already been discussed by Jafar. It can be cement, screws, bone grafts, metallic augments, metaphyseal fixation in the form of cones or sleeves, and some So this is general guideline. How can you assess on the X-ray, see the joint line, see the epicondyles, then assess the bone loss. And always anticipate that whatever you are assessing, it's on table you are going to find more. So this is a Morgan zone classification for the 2-zone fixation. At least 2 zones should be fixed properly. So for small defects, you can use bone graft, which can be structural or which can be allograft, autograft, any form of graft, whatever is available. The bone banking system, which I have seen in AIMS, generally bone bank is not been, it's not present in most of the hospital. It's easy to, I was in Army Hospital RR, where it was proposed that we develop a bone bank. Developing a bone bank doesn't require much of thing. Nowadays even, I would be surprised, hospitals are doing the industry grade of this thing, irradiation. So it's possible even in hospital. I'm forgetting the name of the hospital. I was surprised when I found this thing. So you can use cement with or without screw, depends. It's already been told, my half of the job is already been done. So you can use autograft, allograft, impaction grafting, structural. I'll talk a few minutes about impaction grafting because it is also not been done everywhere. The real impaction grafting is where you create a void, fill it with a reamer, and then keep on impacting. It's a very time-taking, tedious, boring kind of process. It takes at least 30 minutes to do impaction grafting about 3 to 4 centimeters. I've seen in a few cases being done because I've worked under Professor Malhotra. He loves talking about bone grafting and bone banking. So impaction grafting is a actual real grafting. But it should be a very tedious, you need to have all the shapes of mallet, which can be modeled according to your own needs. You may require a mesh to do impaction grafting. Structural bone graft can be used if all other things are normal, but you may require a stem extension. You will require a stem extension. You will require some metaphyseal augment to do structural bone graft. APCs are required, especially in young patient. We are thinking of future revision. Patient is going to last more than 20-30 years. He's got life beyond that. Then probably yes, you will require bulk allograft. Metal augments, there is no problem with the metal augment, except you should not use metal augments more than 15 millimeter, because then the problem starts of stress shielding. There was a topic about stem extension that I'll talk about only 2 things. There are 2 kinds of stems you can use, either short stems or long stems. You can use it in a cemented or an uncemented fashion, depending on the age of patient. If a patient is, you are not thinking of future revisions, there was a infection, you want some antibiotic load, use a short cemented stem. When patient is relatively young, he is going to last, the implant is not going to outlast his life, then try to do uncemented. This is just a basic concept. So stem selection, you can, it depends on basically what you want from the stem, other than method of fixation. In certain cases where the defect is severe, bone is bored, you need to have offset stem as a backup as well, in each and every case. So metaphyseal fixation, it has to be biological fixation, so you require impaction grafting, you need to fill the large defect, and it gives you immediate structural support. Finally, coming to sleeves and cones, when to use cone and when to use sleeve. When the defect is contained and large metaphyseal defect, one need to use cone, but nowadays I think companies are not even providing cones. And when there is an uncontained defect, then you need to put on sleeve. Cone is more of a biological thing because it matches to the bone, its structure, properties, they are closer to the bone, so they are more physiological, and bone regrows over cones as well. There are a few examples where TM cones are used in the femoral defects. It is a loss of metaphyseal bone, but it was a contained kind of defect. The cortex was relatively preserved. So tantalum cones can be used on both the sides, femur and tibia, but it has to be used in contained defects. And it's, I have already told that properties are closer to the bone. There are a few examples where we used femoral cones and as well as tibial cones. The various shapes and sizes, they are made, they are custom made. There are a few examples where femoral cones are used. One more example where tibial cone was used. And few words about sleeves. The only important thing is if you are using a sleeve, you have to use a rotating surface above the sleeve because it reduces the stresses on the sleeve. Sleeve is a weight bearing structure. It requires some time to integrate, and in India generally they do not give us fully coated sleeves. The sleeve is only proximally coated, and in cases of bone loss, half of the sleeve is exposed. It is not in contact with the bone. So when you are using sleeve, try to use a mobile bearing. There are a few cases where a sleeve being used. Sleeve can be used for both femur and tibia. You are expecting, like in this case, there is a metaphyseal bone loss. That is the reason sleeve was used. So this is a basic algorithm. When you can use cement, metal augments, bone graft, whether autologous or allogenic. When you require impaction grafting, advantages and disadvantages. So as when I started the talk, I said two things are important. What is anticipation of bone loss, and second is preparation. Always be prepared. Each and everything should be in your armamentarium when you are opening up for the surgery. Thank you.
Thank you, Satish. I think it's very well explained on bone defects. Only two short comments. The cones and sleeves. Cones are basically fillers, and sleeves they do provide the stability, and you rightly mentioned the same. The second is about the stem. Whenever we are using the constrained implant to take care of the intra-articular instability of some extent, I think these are the conditions when the extension stem must be used, because we are adding the stability to the joint by the use of the constrained implant or semi-constrained implant. So these are the cases where the extension stem is a must.
Sir, we have to identify that we require two zones of fixation: metaphysis, diaphysis, and surface. If either of the two are good, like if there is hardly any bone defect, you do not use stem. If there is a loss of metaphysis as well as surface, then you require a stem. So it's very simple, sir. The use of stem is when you are not having there's a bad metaphyseal bone as well as surface is bad. Then you require a stem.
Yeah, very rightly mentioned. The good fixation of the components and the stability of the joint, then you don't need the stem.
Exactly, sir.
Thank you so much. Thank you so much. Any question from you? Thank you so much, Dr. Sati.
Can we have a big round of applause for Colonel Satish Sharma? The next, may I request Dr. Avatar Singh to speak on constraint poly and stem extenders, when and why. Can we have a round of applause to welcome him?
Good afternoon, chairpersons and dear friends, and thanks Shubhang for the invite. And I'm thankful to the Indian Army colonels for explaining most of the things which are there in my talk. And I'll be talking about the stem extenders and the choice of constraint. So friends, there are a lot of indications for stem extenders in primary TKA. When you are treating the bone defects, especially the uncontained bone defects, then osteoarthritis with stress fractures, previous hardwares in the tibia or the femur, and then treating severe varus and valgus deformities, or osteoporosis associated with rheumatoid and otherwise. And then a lot of obese patients these days we are getting, most of them they will need stems. And to add on, you can treat fresh upper and tibia fractures associated with osteoarthritis. And now people are talking about the height also. The taller people will also need stems, and a lot of studies are going on about that. There are several advantages of the stems. They decrease chances of aseptic loosening by increasing the mechanical stability. They offload the upper end of the tibia, reduce the micromotion between the bone and the implant surface. They correct the deformities as well, and they restore alignment, and they convert tension forces into compression forces. So what is the ideal stem length? And what is the ideal canal fill ratios? Stems can be short if they are up to 80 millimeter length, and they can be considered longer if they are more than 80 millimeter. And a minimum of 4 centimeter of diaphysial fit should be there with the stem. We shouldn't be less than that in the distal fragment. And canal fill ratio should be around 0.85. So this has already been talked about, the short stems and the longer stems. And there are advantages and disadvantages of both. Disadvantage of metaphyseal stems are that they are difficult to remove because most of them they will be cemented, and there will be more bone loss if we need further revision. And they don't serve as reference for aligning your implants. Then about the diaphyseal engaging stems, they are generally uncemented in the diaphysis but cemented in the metaphyseal. So they are a kind of a hybrid, and they achieve press fit fixation in the diaphysis. And if you need a longer stem, say more than 150, especially in the femur, they need to be curved stems, which are available with some of the companies. So friends, as of any normal TKR, you need to assess your patient, especially about the bone quality, bone loss, severity of the deformity, associated stress fracture, which is not that too uncommon, and about the obesity, previous implants, and the height of patient as well. Few examples: if you have a contained defect which is more than 1 centimeter deep, then you need to freshen it up, put some screws, then you must protect this with a short stem. You can opt for longer stem if you want. Then about uncontained defects, you will see many of these in your practice. And I address most of them, rather all of them, with autologous bone. I have never used bone from the bank, and very rarely I have used those implants which are now available. We need to cut tibia slightly little more, maybe 10 millimeter, that's the upper limit, because you will need more bone for reconstruction of these defects. Make an oblique osteotomy to the defect, and you should have 80 to 90% of the bleeding bone in the bed. It should be very flat osteotomy so that the graft fits intimately with the bone. fix them with 4 mm cancellous screws, 2 of them, but put the screws in a direction so that they don't interfere with the direction of the stem, because you have to use stem in these patients. And cement should not be allowed to creep between the graft and the recipient bed. And then you must protect this with a stem. And then when you are treating severe varus or valgus deformities, there is enough literature now which suggests that you must use stems, and they show better results. Otherwise, they'll come back, these deformities, and you have early failures. Some of the examples of severe deformities: bilateral stems, severe osteoarthritis with flexion, varus. These are from my early days of navigation, 34-degree flexion deformity, reconstruction of the defect. You can balance these knees after the reconstruction, and this is a couple of years later. Another very severe windswept deformity. You could take his knee into hyperextension, severe varus, and initially I thought that I'll need a hinge or a CCK to sort it out. But surprisingly, after good releases, good resection of the bone, I was able to solve it with a normal knee, just a constrained insert, and that to PS, not the CCK kind of. You can reconstruct your defects by using these meshes. I have no experience with that, and I rarely use these augments because they are expensive and their availability is also a problem for a normal orthopedic surgeon. And then you have a lot of these osteoarthritis with stress fracture of tibia. So one thing I will recommend is that you should always have a long leg. I can share my personal experience with you. About 2 years ago, I did a TKR. I was very happy with the result. In the theater, when I went to the room, she was complaining of pain. I examined the knee and there was a fracture. So I had to go back to the OT, then revise the tibia with a long stem extender. So always take a full length X-ray so that you don't miss on these things. And it's better to treat them at one go rather than treating your fracture separately and then coming on to do the TKR. And it's very well highlighted in the literature as well. You can kill 2 birds with just 1 stone, sort it out together. Couple of examples: severe osteoarthritis, osteoporosis, stress fracture, and that's the result. Couple of more patients. And then some of these patients, you may, especially if the fracture is little more proximal in the metaphysis, you may have to add plate to get stability. You will not need this in all your patients. And if you have previous hardwares in the tibia or in the femur, you should definitely use stems. And coming on to obesity, it has been shown that they will always do better with stems, especially on the tibial side. Couple of examples. So in this patient, I had to do a hinge also because I had to resect the proximal part of the femur because of a previous fracture. Then osteoporosis, I always prefer to use stems. Acute intra-articular fracture, I have a couple of these patients which I couldn't get the slides. This is from the net. It can be done very easily. Just remove the proximal part of the tibia and then put an extender. They heal very well. Then coming on to the constraint selection, this has already been discussed by a number of speakers. I don't have to speak much about this. Constraint selection, friends, depends upon your stability, your collateral ligaments, degree of bone loss, and integrity of residual bone. And what to choose is entirely your choice. You can use a CR knee, deep dish insert. Throughout my career, I had been relying on deep dish inserts and some PS inserts. Very rarely I have used the CCK insert. Thank you so much.
Thank you very much, Dr. Avtar. It is a nice talk. But how many defect is there? If it is one third or percentage, you decide to put the stem. Suppose there is defect in the tibia on the medial side. If it is only 10% or it's 20%.
If the defect is, say, more than half of the keel's length, I will use the stem. I calculated from the
more than half of one condyle of the tibia.
Keel of the tibial implant I'm using.
And in all, and how you decide that in all osteoporotic patients you put stem?
Yes, most of the osteoporotic patients.
But some of the surgeons, they don't use the stem.
I believe that when you are treating osteoporosis, severe osteoporosis I'm talking about, when you extend them, and if you don't have a stem, your tibial slope will tend to change. So to protect that, I use stem in these patients.
But also, don't you feel, sir, that there can be a stress fracture at the tip of a stem in case of osteoporosis? Because osteoporosis is a contraindication, especially on the female side.
No, there cannot be any stress fracture, and I have not got any till date.
Because most of these stems are dangling stem. They are not tight fitting in osteoporosis.
You don't need a tight fit stem in this situation. You just need a dangling stem.
But you agree that even in a very severely osteoporotic bone, like a rheumatoid, even if you don't put the stem, and then if there is no instability of the joint, in due course of time the bone becomes much stronger.
You can get away with that.
Right. But the instability or the constrained implant, probably that is the main indication.
Then you will definitely need that. Thank you.
Thank you so much, Doctor. Thank you.
Thanks a lot, Dr. Avtar Singh. So may I have the honor of inviting Dr. Amit Sarsia also on the dais as chairperson. Dr. Amit Sarsia, please. He is our orthopedician from Railway Hospital, Firozpur. Kindly join us on the dais, sir. And may I have the honor of inviting Dr. Shubhang Agarwal, who will be speaking on Is Robotic the Solution for Everything? Can we have a big round of applause for him? Dr. Shubhang Agarwal, please.
So good afternoon, and thank you everyone for attending this program and making it a success. And I would like to take the opportunity to thank Dr. Ronan Roy and Dr. Natesan for giving us the opportunity to be able to host this program. And I thank all the faculty who have taken out time and traveled all the way from all over the country. And I hope that we are able to do justice to your time. Right. So I would like to speak on robotics in TCAR. Does it solve all the problems? So just, in the morning there was a query left at the end of the surgery if the flexion deformity, if it was showing a little flexion or not. So this is just from the side. We wanted to show just after the final implantation. Just after the final implantation. And that's the final tracking without touching it was 6, and that is what we aim at. Okay, so we started this hospital in November 2017. And why did we choose robotics in the operation theatre? Accuracy, precision, of course, partly it was glamour. So apprehension for starting robotics was cost, the additional cost, the stress for it, the transition for navigation. We've been using navigation since 2008, patchy in the last 10 years. Learning curve, increased surgery time. We were worried if there'll be infection or not. Stepping out of the comfort zone and actually, learning something new. When something is going on right, why do you want to change it? Why should we change it? Changing the implants that we were using earlier as a routine, staff training, and results, will it actually work, what they are promising? And extra costing issues for our patients. Finally bought it. First we had the Navio, now we have Navio and Cori. Initial 20 cases was euphoria. The staff just needed one sawbone demo because they were doing navigation, so they were able to adapt to robotics also. The first 5 cases we opened up all femore, conventionally cross-checked with jigs. We had some hip registration issues with the side supports. And questions to be answered in total knee replacement. Exposure, not yet robotic, still have to be there. Osteophytectomy, not robotic. Planning, of course, robotically possible. Bone removal, robotically possible. Release is robotically possible, deciding how much. Ligament balancing, robotically possible. Alignment is robotically possible. Tracking, it is robotically possible. Complex primary bone handling is robotically possible. Soft tissue handling like SNPs, cordyceps snip, and other special exposure techniques, not robotically possible. Avoiding complications, that's the idea with a disclaimer. Implant options, somewhat possible. We've been doing other company implants with the CORI system. And improve outcomes, yes, somewhat possible. It's technology in evolution, and more, more data needs to be, and more robotic surgeons need to pool their data and come out with, a scientific basis for showing that it's better. That's how you plan. So bone removal, ligament balancing, deciding the releases, it is possible robotically. Alignment and tracking, of course, it is possible robotically. That's how it is. You can see, you've seen 2 surgeries already, and you'll be seeing 1 robotic uni now. So that's the tracking that we aim at. Avoiding complications, like I showed in the live surgery also, if it can show red, you can just keep on rubbing it with your burr, nothing will be cut. It'll just turn red, and it'll warn you that don't go there, because it's already finished, that part. Implant options, now this is another company, Merrill Implant. We've used CORI to do it, so it's a very versatile system. It helps you plan. Smith & Nephew may not like it, but it's a good thing about their system, that it's a versatile system and you can adapt it to use other company implants also, which is not possible with all the robo companies. So that's one advantage of using CORI. Improving the outcomes, what does it mean for the patient finally? Minimum retraction, minimum ligament release, so minimal pain. Minimal bone removal, perfect tracking with the kinematic balancing, minimal bleeding and risk of embolism, we don't open the canals, better alignment and tracking, will it lead to long-lasting knees? So this is a small study that we did, the consecutive 508 patients done robotically in 890 knees, 126 unilateral, 382 bilateral, average age range was 46 to 84, most of them were females. And around 85 kg was the was the average weight. Implants used, various implants were used. Tourniquets, 140, you saw no tourniquet surgery. I worked with Dr. Nilansha 20 years ago, and he's still doing surgeries without tourniquet. We are moving there, but it takes a long time to adapt. First is the mindset of the surgeon. Once you get there, then you need to train your OT staff, be convinced, but don't get sold to no tourniquet only. You can keep the tourniquet on in the beginning, unless your anesthesia and everything else is perfect. You cannot do no tourniquet, just right for all the cases. So drains we've stopped using now. This was the time we were using drains. 63 cases we gave spinal adductor canal block and cocktail injection intra-articular. And bilateral we used to do combined spinal epidural at that time. We've stopped doing it completely now. This was the medication protocol. We give Nicoxia and gabapentin in the morning, and we give adductor canal block. Used to do the IPAC earlier in those patients, now we don't do. It's again operator dependent. Intraoperative cocktail is saline, ropivacaine, clonidine and epinephrine. Patients who are hypotensive, usually lower baseline blood pressure, we don't use clonidine in them. And otherwise, anyway, this gets divided into 2. And we give one Magnex Fort, which is cefoperazone sulbectam at induction. And one, it is 100, no, it is 1000 at Trenexa at induction, and one at closure again. And we give one 750 mg amikacin for selected patients at closure. So 863 varus knees was average pre-op deformity of 13.2, and 27 knees average 10 degrees of valgus. We were able to achieve 96.8% planned target, mechanical axis in with less than 1 degree variation. And 7 out of 225 had 3 degrees variation. So we recognized in these 7 patients, we recognized error in tibia vara, in the tibial varus and in femoral valgus, probably because of hip registration issues. Like today also you saw, in spite of being a live surgery and 300 instructions, still the side support was a little tight than what I would want. So circumduction of the hip, the side support can actually hinder it. So we use the green leg holder for that and becomes easy. So no pin was knocked down or moved even in a single case. Trackers were changed in 9 cases during surgery. We ETO them to save some costs. Besides the first 5 patients, 2 patients were rechecked with conventional jigs intraoperatively. We opened the femur, put the jig and rechecked if the bone removal was okay. 1 patient had cellulitis at the tibial pin site, just 1 patient of all these. 2 had superficial wound infection needing IV antibiotics for 5 days at 7 days onwards. And 3 knees had superficial wound infection not needing any IV antibiotics. No clunks. 1 patient had a bilateral patellar subluxation almost 6 months down the line from surgery, and he turned out to be asymmetrical polyneuropathy, which was probably not detected in the earlier preoperative examination by us. So 83-year-old had a cordyceps rupture 3 weeks, which was repaired and immobilized for 4 weeks. Another 78-year-old gentleman had a spontaneous hemarthrosis 3 weeks. He started driving a scooty at 20 days from surgery. We evacuated the clot, and 2 weeks later he subsequently bled in the calf, which was again evacuated. So no blood dyscrasias were detected. The patient's doing well now. DVT was detected in 1 patient of all these, obese, classical patient. In spite of the prophylaxis, she developed DVT. All patients more than 65 years of age or 70 kg weight, we give them post-op DVT prophylaxis for 3 weeks. We had MI in 2 patients post-operatively. Both were unilateral patients only, both second day post-op with previous histories of ischemic heart disease and CKD, either of the 2. Both were resuscitated during physiotherapy. They had it in the corridor in the ward. The MOs were present there, resuscitated, and both did well. One of them had angioplasty in-house itself. No stress fractures were seen. So distinct advantages of robotics TKR, unbelievably detailed planning. You've all seen what the eye can't see, we can see with artificial intelligence algorithms. Extremely reliable sculpting of bone in ways which is not possible with conventional tools. Kinematic balancing, much faster functional recovery, and no opening of the bone, so minimum blood loss. Thank you for a patient listening.
Thank you so much, Shubham. It's a wonderfully done surgery and good talk. Now, robot is a new kid on the ground. Now, when we started using the computer navigation 2005, we realized after a few surgeries that the computer was suggesting a larger femoral component. Now, today we saw you also choosing a smaller component than what was initially planned. So, do you do it in a routine? I mean, is that your observation?
It's our observation, yes. I think the other surgeons will also concur that it definitely suggests bigger. I think what it takes into account is the outermost point for suggesting that mediolateral of the implant. So with the company that we are using, Smith & Nephew, they've got an option of a narrow implant, so you need not change the size, just change the mediolateral dimension. So most of the times you have to undersize one mediolaterally.
Yeah, and 2 recent cases that I revised, the robotic knees are done, and in both these cases we found out that this femoral component that was chosen by the earlier surgeon was larger, and you rightly mentioned. Yes.
Can I have one question? Sir, your robot can't choose correct femurs for you. It requires more exposure than conventional, sir. Probably for robotic surgery. You require 2 additional pins. Initially it's a time consuming.
Yes.
So what are the advantages the robot is giving to you over navigation?
Okay, so one thing in navigation, there is a burr removal of bone exactly where it is. In navigation, unless you have the spring tensor, which is rare, not everybody gets it, not all the systems have it. So unless you have the spring tensor, you cannot really assess your ligament tension in navigation. All it does is tells you your mechanical axis, and then you take the cut. And like I showed today, you take the cut, but the cut is still wrong. You think it is correct. We have been jamming your femur and feeling nice with nice fit of the box preparation guide, and you feel it's a very nice fit, but actually from the plan you've left bone because the blade has played. Now whether this is going to be clinically relevant or not, time only will tell. This is a technology in evolution. More and more surgeons are using it, and it's giving good results so far. The functional recovery, alignment, everything looks better.
Navigation, the trackers where the small amount of fat will spoil it. And so I think the robot is not having that issue.
No, it doesn't have. The trackers are nice and they are ETOable. So you can just re-sterilize them, and even if there's a splatter of blood, you just wipe it off with a wet mop, it will mostly be okay. After a few cycles of FETO, it will bubble up, then it doesn't detect it, you have to discard it.
We can do 20 cases with one set.
Yes. I didn't want to disclose that, sir.
No, that's a major saving.
And about the oversizing, yes, it's a problem in, I'll say about 1 out of 10 patients. Not all the patients will have oversizing problem. And I can suggest that you chop off the anterior part of the femur with the saw, and then we should not have this oversizing problem. And then you should register after that chopping off the anterior lateral femoral canal.
Yeah, so just like you do your conventional, you remove all the osteophytes, so you get a better size. Yeah.
Very nice.
Thank you.
Thank you so much, Dr.
Thank you, Dr. Shubhang Agarwal, and I also take the opportunity of thanking the chairpersons for this session. So we are grateful to you, sir, for your presence here. So next, I think we can take the time off for tea, because let it be running, because we are just falling short of the time. We are roughly 1 hour behind the schedule. So for that thing, I think we can start with another very interesting third live session by Dr. Narendra Vaidya. For that, can I have the moderators for this third live session on the rise, please? Dr. Ramesh Sen, Dr. Nilen Shah, Dr. Avtar Singh, and Colonel Satish Kumar. Kindly grace the chairs with your presence, sir. Can we have the live surgery feed? The topic is again the robotic topic. It is a robotic unicondylar knee replacements by none other than the expert in this field, Dr. Narendra Vaidya from Pune.
Yes, hello everyone. Can you hear me in the auditorium?
Yes, sir.
Yes, so we have this patient who is a 51-year-old male patient with a typical anteromedial osteoarthritis. I'm going to do a medial compartment UK. So now I'll start with the indications of selection of my patients of the UK. So typically I select the patients who are whose BMI is less than 25 first of all. Number 2, they have a typical anteromedial osteoarthritis. I do not do the MRI of the patients preoperatively, but do the true lateral X-ray to see that the defect is not going posteriorly, posterior to the midline of in the coronal plane. Clinical stability is very important. ACL impact is important, but it is not as important as a patient whom you are taking for Oxford, because that is a mobile bearing knee, whereas this journey uni is a fixed bearing knee. So you can see now I have done a paramedial approach, parapatellar approach. We take out the fat pad. Is the vision clear there?
Yes, it's clear, Doctor.
Very clear.
Right. Retractor.
So this is probably without tourniquet?
No, I applied tourniquet.
Okay.
I have elevated the limbs, no edge marks, and I'm comfortable with tourniquet there. So you can see this is a very nice case for a unicompartmental. Number 1, the patient is thin. Number 2, the patient's age is 51. That is, both the extremes are good candidates for uni. Number 3, he has got only involvement of the medial compartment. You can see the bare bone there on the medial side. Now in uni, I would like to say some things that in uni, the principles are different than the total knee replacement. In TKR, our aim is to correct the deformity, whereas,
Dr. Vaidya, what is normally the length of your incision? It's like your TKR or slightly smaller?
Sorry?
What's the length of the incision? Length of the incision.
Length, I have taken slightly bigger incision here, about 4 inches. More than length of the incision, it is the accuracy which is very important for me.
Right.
And I have taken slightly 1 inch above the tibial tuberosity, and this is just above 1 inch above the patella theta. So now I will be placing the pins outside the incision anterior posteriorly.
And that pin you have put is for retraction.
Yes, because I cannot have somebody standing in front of me because the camera will come in the way of my camera.
Yeah, that's a good idea actually.
Yeah, so I put these 2 small pins there. You have to ensure that you are, in pin placement, you are in the center of the bone and not going transcortical.
Narendra, will this impinge the quads or the quads are retracted?
Quads are retracted.
Okay.
I have taken that actually retractor there. Yes. So you have to ensure that the pins are unicortical. This is at a 45 degrees angle to the tibia. So now these are the trackers which are very fast trackers, and they have got fast registration properties, so you have to put it in the femur and tibia. You have to ensure that it is visible on the screen. You can see now, is there the picture on? Yeah, so camera 1 is big, right now? Okay. So once I am done with this, I ask you to change the camera.
But patients इतना मानते नहीं हैं.
Right, so you can see in the screen that I am taking it throughout the range of movement and ensuring that I am visible throughout the range of movement. Yeah. So now we go for the next. You can, now the setup was slightly different than what Shubham did. So I generally like to operate the screen myself rather than the technician operating it. So I have kept this tab which is draped here on the other side of the patient. Generally I have a Mayo trolley here and then it's easier to operate. But here the situation is slightly different. Picture. So now we have to register. I don't put those pins. There are some laser marks on the tracker. So I register these laser marks itself. The medial malleolus. So I push. Yeah. So medial malleolus, lateral malleolus, and then you have to take the limb through a circular range of movement without moving the pelvis so that there is no error. So we determine the center of the hip, neutral alignment. Then that was a non-stressed alignment. Then I take this Z retractor and I put it on the medial compartment, press with my thumb, which gives a physiological pressure to the joint, and then take it through the range of movement. So you can see there is the opening on the opening of the joint. This is to assess the ligaments. So
that's a good option.
Right, so after this, we have to start the mapping.
We must embrace.
First point is the tide mark, the center of the femur, the most distal point, most posterior point, and then you have to just move it on the medial femoral condyle. So it creates a real-time virtual image of the medial femoral condyle. Any questions up till now?
How many lateral unis do you do?
Sorry?
How many lateral compartment unis do you do?
I have done only 2.
And you take the same approach or you go from the lateral side then?
Lateral side.
Okay. And the patellofemoral joints, how many you have done?
Patellofemoral 4 to 5 I have done, I think.
Okay.
That was mainly post-traumatic patellar thing. So this one point I would like to emphasize. This now, can you focus here and show my tracker? See, it is very difficult in uni to get the tibial rotation right with a conventional instrument. Whereas in this, you can put this tracker in the notch here and take it, and you can see that it is not properly oriented. So I make it parallel here and go back and then take it again. So my orientation is absolutely parallel. Can you appreciate that now?
Yeah.
It's parallel to the central line.
And do you have to register till the far point on the posterior side?
Yes, that yellow point which is here right now is the furthermost point. Sometimes it may not reach there, but that's fine. That is to, even in tight knees, it is sometimes difficult to reach there. But it has already calculated the slope, so that's no problem. If there is some remaining bone, you can take it off with either nibbler or the socks, etc.
And you remove the medial meniscus beforehand or you do it later?
Say again.
Removal of the medial meniscus.
Meniscus later.
Later, after you have made all the cuts?
Yeah. Actually, I will remove whatever is possible right now.
Okay, okay.
Just so that it doesn't come, but I will not try to remove the entire thing right now at this stage.
No, I need tea. Tea. No, normal tea.
Okay, so now we are done with the registration part. Now you can actually show the camera 2 as a large listing for planning. Camera 2. So you can see the robotic screen now. So now this is a planning screen. You can move all the components in all 3 directions for both tibia as well as femur.
Dr. Vaidya, can we remove the surgical video?
Sorry?
Can we remove the surgical camera now? Because we can't see the upper right corner.
Oh, actually, PIP is blocking the robotic screen. So, Vinay, can you just remove it and just show the robot?
I want this screen to be big, the robot screen to be big.
Yes, but when we do the robotic screen big, the PIP.
I don't want this image right now.
So, for a minute, you can just remove.
For the time being, only the robot screen.
Vinay in the OT, can you please switch off? Yes, thank you.
Yeah, they are doing it, I think.
It's done, sir.
So, yeah, it's okay now?
Yes.
Yes, so we have this sticky images where you can see that how the implant is going to fit on the bone. Yellow is the bone and the silver is the implant. So it is like this. But I like this cross section. You can see this cross section, which is gray is the implant and yellow is the bone. So I matched this particular thing. It's actually child's play. You have to just match the component to the natural contour of the bone, and this is my basic planning at this stage. Ultimately, when we see the balance the knee, we can again adjust it. So this is the tentative sort of alignment which will be there. I'll move the prosthesis medially. So the beauty is that you can actually visualize it before cutting. So the advantage of robot is that you do a virtual surgery on computer first and then take cuts, which is an extremely great advantage. On tibia, generally I am having a fixed planning that I do only 5 to 6 millimeters of cut. I have aligned a midline here and then slope I keep it 5 degrees. So this is my standard planning. After this, now this is the graph which I am getting. So you can see that in extension it is quite loose, whereas in flexion it starts becoming tight. So I have to balance this. So just remember this graph, which is extension loose and flexion tight. So I will distalize the femur now. So to tighten the extension gap, so I have distalized it and anteriorize it to take it, like this. So this is my graph now. So I have got a completely sort of balanced graph, which is from 5 degrees varus preoperatively to 2 degrees varus. In unicompartmental, the aim is not to correct the deformity, but the aim is to resurface the bone which is damaged without disease. So undercorrected. Overstuffing of the uni is always a problem, and that's why you should never do it.
So
without the planning.
Was good. And Dr. Vaidya, in doing robotic uni, I think we are addressing most of the issues by the femur. Not by altering the tibia, but by altering the femur.
That's a great point. Actually, see, in the uni, most of the failures occur on the tibial side. So my tibia is always constant, 5 to 6 degrees, 5 to 6 degrees of slope and 5 to 6 millimeters of the cut. That's a standard thing. So you can adjust all and balance the knee with complete repositioning of femur. So if you saw that, we moved the femur superiorly, that means proximally, and we moved it anteriorly. So actually the effective movement was diagonal. Can you appreciate that point?
Yeah, we could.
That's why we could correct the extension and flexion deformities both. Extension laxity and tightness on this. Both we could correct.
And another thing which I have analyzed about this technology is that our younger generation will be good at this technology because we are old timers and we had never no exposure to the computer technology. But the younger generations, they play with the computers like anything. And hopefully they will do better with robotic technology.
So now you see this robotic screen where articulation is going to be there. So you move this and you know how this is going to articulate. So it is showing you everything. Before actually starting to operate, it is showing you everything.
Narendra, one point, the femur is 5 and the tibia is 4. So is that usual or would you try to get a larger tibia? Because if the failure mechanism is...
I will believe this basically robot because it has showed me my mapped area and it has actually done this thing. But after trial you can always change the tibial size. But generally I go by the robot size.
Would you try to put the biggest tibia possible?
Yes.
Okay.
So now I have started preparing for it.
Can we have that other screen, surgical floor camera on?
Yeah. So keep the robotic screen larger and
PIP
operating screen smaller. Boss, larger ये रखना है और ये.
Vinay, please switch on the PIP. Yes. Robot. We are ready.
See, actually unicompartmental replacement is a great surgery in select group of patients. And the main determinant for the long-term success or long-term survival of a uni is the accuracy of implantation. Uni is very technically demanding surgery conventionally. And no company, I have used many company implants, but no company's implants are actually precise. And there are a lot of variations. Just to tell, people read about Oxford and talk about Oxford, nothing against Oxford, but in last year I revised 8 Oxford knees done by a very good surgeon. So it's not the surgical problem, it is basically the instrumentation which is not extremely precise and the variation will give all sorts of problems. I have breakage, revised for breakage of poly of Oxford, dislocation of
Same with me.
subsidence, all sorts of various reasons. So with this now, the accuracy is extremely high. Number two, the reproducibility is perfect. The reproducibility, you see consistently the X-rays are same. You don't have, any variation and, any virus in media or, sometimes it is slightly in tighter means difficult to go all the way posteriorly. That time you can change the mode to speed control. Right now I am just doing the exposure control mode.
While you are shaping the femur, sir, can I ask you, if you choose between mobile bearing versus fixed bearing uni, what will be your preferred implant and why?
See, basically my preferred thing is robotic UKR, not implant wise. So any implant put right will give you good results. Now you see the registries, then you have seen, we can see that even the fixed bearing has got, initially Oxford or mobile bearing results were better. But now you have many papers coming up with fixed bearing which are equally good as far as the survival is concerned. With robotics, it is going to add accuracy, and I think what I think is most important rather than type of implant, it is the accuracy of implantation, which is the most important determinant as far as the results of uni are concerned.
So what are the modes of using the burr?
Yes, we have two modes here. I will just show on the screen till they are cleaning it. So you have this exposure control and speed control. So I am using the exposure control in which the burr will continue to rotate and it will retract and come out of the sleeve. While in speed control, it will stop rotating if I am out of the zone of cutting. So I am almost done now. This part is a bit tricky, posteriorly always, and if required, you can change the mode of burring.
Are there any special tricks for burring, or you just hold it and do it?
Actually, if you are doing arthroscopy, it becomes easier because I am looking at the screen and burring. You should not look at the bone and do the surgery. This surgery after exposure, you have to look at the screen and do it. So, burring you have to come from superior to inferior and go clockwise. So that is the only recommendation from the company. You should not go from below upwards to create more bone dust. So I will prepare the logos now. So all the, going back to conventional and robotic, all the conventional instruments which are not very precise with any company are replaced with one intelligent handpiece which I am using. I have not used any other instrumentation right now. So this one handpiece is doing all my work. So my logos are also done now. Now for tibia, so for tibia I will use the tunneling method. So I will protect the MCL here. So instead of going from top, what I do is I tunnel this and go vertical, directly posteriorly, removing the bone. You have to take care of your eyes. There are a lot of sharp bone pieces which come out. Generally, I use a helmet, but today I am using this screen shield. But you should take care of your eyes when you are doing robotics, with especially burring technique. So unlike TKR, where we can use various modalities, in unicompartmental, only burr, total burr helps us because it's a restricted area, you can quickly finish it off, and it is absolutely precise, so there is no need of refining anything.
So here it appears that the burr has kind of migrated a little bit more than the intended area. Is that so? I mean, it must be a very small thing. Like I can see some impression on the intercondylar eminence. I can see a little bit of impression on the anterior tibia also.
This one?
Yeah. So
actually, it doesn't damage it. Now I am touching it here, not burring, but it is showing me that I am on wrong place.
okay.
My burr is not on right now, but it will, if I go out of the zone, then it will show red. It is like a signal given by it. Actually, it has not removed the hole. So as I told earlier, this camera is a faster camera, so the reaction time is almost 4 times faster than the Navio. And that's why, the chances that it will damage the normal bone is very slim, or almost negligible, you can say. So that's it. I think I will give a wash and show you the surfaces.
Nilan, there's also studies which says that if you have like saw cut on the proximal tibia and very smooth, whereas if you have the burr, you have these small serrations and depressions. The cementation actually is much better, the fixation of the implant.
They are coming up with the data for that. It's very logical. If you have a rough surface, then cementation will be better.
As you saw, when Shubham took the cut, there were a few rough surfaces.
निकलेगा थोड़ी, अब वही रहेगा। धोगे तो भी निकलेगा। It's very easy.
So you can see the surfaces absolutely. Just check for any posterior osteophytes. There are none. So we are good to know. Just to remove those small green spots, this raft is very useful. This has got, one smooth side and one double side. So just rasp it lightly from all sides to remove any spikes of the bone. Yeah. So this side 4 is I think it is pretty absolutely perfectly packed.
I think this Cody system is the most versatile. If you have to go back in planning, just touch of a button and you can refile them. Which is not
This base plate has got small spikes, so it fixes tentatively. Before making the lug holes, there are small lug holes here. I always like to do some K-wiring because sometimes the bone can be sclerotic and it can, develop a stress fracture there. So I will do that and then this punch will.
That's a good point, similar to what I was saying in the morning,
Correct, yes. So this is the 8 poly which I am putting in right now. Yeah. So now I check what is the alignment and how we are doing towards Mango. I figure out my lesson. Just clean the tracker. Yeah, so we plan for 2 degrees of virus. We are up to 1 degree virus now, and 2 to 3 degrees flexion, that is fine. And this is my alignment. You can see it nicely, evenly, aligned, and you can see the graph about 0.5 millimeter loose. So I'm not overstuffing the medial compartment. So now I go for the final implantation. Any questions?
Looks very nice.
Yeah.
Have you done unis with a medial release also? Little bit?
Sorry?
Have you done unis with a little bit of medial release also?
Generally, I don't do much with it. Mostly not. I will rather adjust it in the positioning of the implant.
Okay.
In general, for UKS, there's medial release is not allowed.
I know it is not allowed, but I think a fixed bearing uni may tolerate it.
For fixed bearing, some people say that it can be done, but I generally don't do it.
And he said that he would do it in ACL deficient knees. Those would have some degree of contracture of the MCL.
Yeah. So, but still, I think you need to be very careful about, because if the moment you do touch deep MCL, the gap opens up.
ACL deficient knees and MCL contracture, they are two different things, sir. In the medial contracture where you require release, uni should not be done. ACL deficient knee fixed bearing unis can be done because they are going to last at least 7-8 years. Generally, they are condition where patient age is 70, 75, and you think implant is going to outlast.
Yeah, but my point is when the ACL is deficient, generally the patients have a fixed deformity in the osteoarthritic process.
Not always, sir. I've done roughly about 10 cases, sir. Generally, there are cases, it may or may not be correct. ACL may be deficient, but still the deformity has not progressed that whole compartment has become arthritic. There is still some time has left, you have picked up early.
So, good point, Nilan, but I think we have studies even from Oxford coming up now. Hemant Pandit and companies who have said that you can do Oxford in ACL deficient knees also with almost same results. The ones where we had failure were the phase 2 trials where the Oxford did not have that much of the curved lip on the actual poly. But now since they've had that, they said you can do deficit in ACL also.
In mobile bearings, the problem is of
Dislocation. If there is ACL deficiency.
So now that the poly
removes this problem.
Yeah, now the poly has much thicker lips,
Curves.
so that dislocation rates have been taken care of. So now they are more adventurous.
Dr. Vaidya, one question for you. Dr. Vaidya, one question for you. Have you ever done ACL reconstruction and uni in the same sitting in a young patient, say around 15, and who is athletic? Uni and ACL reconstruction together.
2 patients who have done. They have done well.
And they were young patients?
Yeah, young active patients.
Okay. So how do you adjust your tibial tunnel in such patients? Or it remains the same?
How do you?
Adjust your tibial tunnels in such patients.
Actually, it's slightly, when we take it slightly medial, the tibial, this surface not exactly going to the base, 1 millimeter or so there. And this doesn't have a fixed touch, the tibia, the journey tibia. So actually it doesn't come in the way of the conventional ACL tunnel also.
So the message is that they can be done together.
Yeah. But clinically, it is, what you can do is reduce the slope. Instead of 5 degrees, you do it 3 degrees or 3 to 2 degrees, and that gives a good stability in peak phase. So that is another way of tackling ACL deficient knee, but that is in slightly elderly people.
But that thing will hold true if there is osteotomy on the other side also, sir. You are reducing the slope on one side and the other side slope is normal. So it's kind of confused me.
So the poly should fit easily, that is the trick, and we have, I think, got everything. So I will check the alignment again because we have saved the tracker from this. Ensure that you remove the entire nose.
Narendra, fantastic work. Can you? I think all of us deserve a good lunch now.
Yes. I will join you in some time.
Yeah. Thank you.
Thank you.
So since sir has already demanded for the lunch, we are going to break for lunch. I would just like to acknowledge the anesthetists in the OT, Dr. Pooja and Dr. Harleen, and the entire OT team who are present in this case. Thank you, wonderful job done. So we would like to break for lunch. There is a master panel on the knee which we were supposed to have, but I think we'll have the master panel of the knee and hip together so that it saves time. Thank you.
Thank you. I take the opportunity of thanking the moderators for this session. Thanks a lot, sir.
मैं चाहना
are medial parapatellar with snip, wandering resident, TTO, VY, femoral peel, banana peel, medial epicondylectomy, and I will put it to you, the subvastus approach. The rationale of the subvastus approach is that a quadriceps plasty is built in the approach apart from the other advantages of the subvastus. Lack of flexion would imply that there is a disease of the anterior compartment, and the subvastus knee addresses this really well. FFD is a disease in the posterior part which can be addressed after you address the anterior and middle part. So those of you who are interested, I had published an article using the subvastus approach in stiff knees, and this has been published in the Journal of Arthroplasty. And this is probably the only series in the literature talking about stiff knees and subvastus approach. So when you do the surgery, you don't do an MUA, but initially do an EUA to see what is the range of movement, what are the collaterals like. You look at the patellar mobility. Mediolateral patellar mobility is there, then the flexion range is also likely to be good, and check the gravity flexion of the knee, keeping the thigh vertical. Technical points are, don't keep it as the last case, confirm that the patient is fully relaxed, and take an adequate anterior incision, tourniquet less. So do the anterior compartment work, and the aim is to subluxate the patella in the lateral gutter and flex the knee without compromising the patellar tendon. The method is you divide the deep fascia, proximal fasciotomy, identify the subvastus plane, subvastus capsulotomy, add a preliminary release, and medial periosteal sleeve you release, subluxate the patella laterally. If you find that that is difficult, release the quads from the septum, clear the medial gutter, excise the suprapatellar pouch, release the vastus intermedius from the anterior surface, remove obstructing patellar and trochlear osteophytes, remove the fibrotic infrapatellar pad, then subluxate the patella laterally, then clear the lateral gutter. This is your anterior compartment work. This is the excision of suprapatellar pouch. This is the quads release. So, view after the patella is subluxed, you can see the trochlear osteophytes here. Then gently turn the patella and remove the overhanging patellar osteophytes and make no attempt to evert the patella. So this is the gravity flexion pre-op. After you have cleared the anterior compartment, this is the gravity flexion. Flexion will increase. Then you flex gently and rotate the tibia externally. Do not force the flexion. Remove the ACL, intercondylar and tibiofemoral osteophytes. May do further release if required, but avoid releasing the pes. And the PCL can be preserved even in knees which have very, very huge intercondylar osteophytes. Always, always, always do the distal femur first, especially for a stiff knee. See if the tibia can be delivered easily. Otherwise, no hesitation in finishing all the cuts of the femur before addressing the tibia. And I think one of the advantages that robotics gives you is that you can finish the femur before you come to the tibia. Actually, I have been doing it since years earlier by just manual methods. And this gets easier with robotics. So this is mediolateral sizing. You can just put the jig and do it the way I showed it in the morning. And then you expose the proximal tibia. Place the spikes properly, full external rotation of the leg, and protect the PCL. Adequate posterior clearance is important because this will improve the flexion deformity. Feel the whole posterior surface of the femur beyond the posterior condylar cut. And again, this is a sign which I had described in 2009, that if there is a cortical rim there, that means posterior osteophytes are retained. So these can be removed, detached and removed. Check gaps in alignment, fine tune the PCL if required, further posterior clearance if required, prepare the tibia and remove all extra bone from tibia until the knee is stable. Maybe. Okay. So then you evert the patella either for patelloplasty or resurfacing. So some quick examples. Grotesque looking knees. You see what has been done. Gravity flexion and the range that can come. Valgus knees. Again the same thing. After one knee, second knee. So this was the gravity flexion pre-op. After anterior compartment work, after total knee replacement. These were the pre-operative x-rays of that lady which I showed. The knee that has been done. And this is a range. And that is a range. 3-month flexion. Another lady stiff. Look at the osteophytes that are there. Intraoperative images. Then post-total knee gravity flexion. Radiographs. Another example. So check the stability of the knee in various degrees of flexion to ensure that the PCL is providing the adequate stability required. Quadriceps spike crusting may be considered if the knee flexion is less than 90 after total knee. If you feel the tight quads, at least the rectus femoris, you may pike crust that. Gentle manipulation and the range of movement can increase by 10 to 20 degrees. This was described by Ranawat, and I have not really been a huge fan of this. So the take-home message is that stiff and FFD knees can be difficult. We need to be gentle, easier to work on the femur before the tibia, consider subvastus, have the compartmental concept of the knee in your mind, clear the gutters and the recesses, and that is the key. We actually emphasize a lot on what implant we are putting, but the implant can only bend provided there is space. What car you buy is not as important as to on what road you are driving. So the recesses have to be really good, quads release, and it can be very rewarding surgery. I thank you for your attention. So now we get on with the, sorry?
Move on with the hip session.
Okay.
Hip session talks? Yeah, hip session. Not the master panel? Master panel?
ये जरा निकाल दें अभी ये.
Hip talks.
ये निकाल दें.
Thanks to Dr. Nilesh Shah.
Just a show of hands, how many are still awake? Not dozing off. Thank you.
Show of hand and a show of applause also, with both the hands also. So next we are going to have, after the knee talks, the hip talks also. So hip talks in a many ways, we have seen the Bollywood. तो वो थिरकने वाली होती है, जब थिरकना बंद कर देती है तो हम आते हैं फिर उसमें उसको ठीक करने के लिए. तो hip talks, we are starting with that. Do you have Dr. Sudhir Garg ready, because his presentation is there? So we'll first of all invite the chairpersons for hip session. Dr. Rajesh Sagar, Dr. Sanjeev Goyal, Major Pardoman is there, Dr. Piyush Sharma, and Dr. Ankul Sachar. Dr. Ankul Sachar. May I have the honor of inviting Dr. Sudhir Kumar Garg. Yeah, please, please.
Thank you. Good afternoon, everyone. So I would like to congratulate Dr. Shubhang Agarwal for this wonderful program. So my talk is very basic. It's on the pre-operative planning in total hip replacement. Today morning you have seen 3 excellent surgeries. They are the outcome of a very rigorous pre-operative planning. They have not just happened today. There a lot of work has gone to make them successful. So, and it's so is in the hip replacement, especially because we not only want to give good functional outcome, we also want to increase the longevity of our reconstruction, because most of these patients, we have seen more and more increasing patients who are very young undergoing total hip replacement, whereas that is not the case in TKR. So we have to ensure that we can maximize their longevity. So for that we have to restore the biomechanics of the hip. So failure, we all know, is multifactorial and it's dependent on the material we have used, design of the implant, what was the surface finish. One example is Exeter hip. You have seen it used to be fully polished, then they went for the matte finish and there was a significant failure, and then they have again gone back to a fully sort of polished stem. So that's one. Surface finish is very important. How you have placed the stem in both cup as well as stem, whether it's the right inclination, whether it's in varus or valgus, they all are important. What is the bone quality? That also determine what kind of implant you can use, and what are the status of the soft tissues and the neurological status of the patient. So through preoperative planning, we can take all these factors into consideration and plan our hip well. So process of this hip replacement begins much before we go for patient is taken to the operation theater. It starts as soon as patient come to us and we decide that patient needs a surgery, that's a total hip replacement. We have to do a thorough planning so to ensure that it's done safely, and there is availability of the appropriate instrumentation. We have the proper inventory of the implants, and we can also foresee what complications can happen, and we have to plan to take care of them if they do happen. So it's a common mistake that preoperative planning is only templating. It's not. It starts right at the beginning when the patient comes to you and you decide that patient needs a total hip replacement. Other important factors are the patient's age, sex, what is the diagnosis for which the patient is undergoing hip replacement, what is the mental status, what is the level of activity of the patient, what is the medical history and current medications, what are the patient's expectation from the surgery, and what is the life expectancy. These are the factors which determine what kind of implant we are going to use, what should be the design, what should be the fixation method, and what should be our surgical approach. So this is all part of the preoperative planning. We also need to look at the ipsilateral knee. We need to look at the lumbosacral spine, whether it's a fixed or whether there is a fixed or a functional deformity. So we also have to take that into consideration to line our implants well. And special consideration should be given to a limb length discrepancy, because that's the major cause of patient dissatisfaction. If we are not able to equalize the limb length, it will lead to a lot of dissatisfaction. Pelvic obliquity is another factor which determines our implant inclination.
studied the dislocation, and these dislocations were in the safe zone only. The cup was in a safe zone, and it did not matter as far as the dislocation rate was concerned. Meaning by, when we are doing all these activities, our patient is doing all these activities, is that safe, reasonably safe? First thing was told that when you take an AP view, as Professor Sudhir told, this was an extra element, that this view for the assessment has to be in a standing AP, not in a lying down AP, because there is little tilt if you see the difference in the two within the standing and supine. That difference becomes much more clear, and obviously this standing view gives the right amount of inclination, right amount of aversion, and that is an important part to understand. So standing AP view, internal rotation, as was told by Professor Sudhir. We all know from our standard perception that the classical element of offset is an important part in the restoration of the offsets. This is very well proved. Now look at what is happening at the lumbar spine. When a person is sitting, if now he is kyphotic to stand because he has to maintain himself, little lordotic, that mobility occurs at the spine to readjust. If his spine is flexible, this is a natural way of adjustment, he doesn't get a problem. But if the spine is stiff, lumbosacral area is relatively stiff, what happens? When he tries to stand up, there occurs a hyperflexion and anterior impingement, even when we have put the cup in a very right position. And anterior impingement leading to a dislocation. So a stiffer spine will make the hip in a properly safe zone unsafe. No fault of hip positioning of the cup. It is the fault of the spine. And they say have the two views in this position. Now look at these x-rays. In a flexible spine, this is the kind of a tilt which happens when the person sits over there. His sacrum, you can see, moves like this in the sitting position. So this cup, which was like this, actually becomes like this in a sitting position. Now this sacral slope, whatever can be measured, it is usually between 10 degree to 30 degree. So this is a kind of a natural range which is likely to be there in a standing position to a sitting position. But there could be hip like this. There is hypermobile kind of a hip. There could be situations when the spine is hypermobile, more than 30 degree also. Or there could be a minimal change. Now look at this patient. This and it is same. So practically less than 10 degree. Now this is the patient where your cup placement will be affected. Because the kind of movement which is required for a flexible spine to allow for the standing position may not happen in that case. I'll give you. So this is the importance that we have to understand the importance of implant position in this kind of a scenario. So I'll take you, if the video works, that when we are sitting or standing, this is the kind of the movement which is happening around between the stem and the cup during this posture. So that's the basic understanding we are going along with. Now look at this. Right now what happened normally? Normally this is along with the sacrum, this is the horizontal line and this is the angle. When the person sits, the cup moves like this. It has moved like this, and this is the axis of the cup opening, and here there is no impingement. Now look at the other scenario. There is no movement here. So here look at it. Because there was no movement, cup stays like this. And what will it will lead to? This is anterior impingement and posterior opening out, and the hip can dislocate out. That is the reason what we need here. We need little more change in the position of the cup to reduce that part. And when the stiffness is happening, when there is a lumbar spondylolisthesis, and all these problems are actually restricting the lumbar spine from a moment. And what it is leading to? It is leading to a stiffness. Now, depending upon how much the stiffness, Now, as Professor Sudhir told the various things, this thing also comes into that very category. When you are expecting the spine to be stiffer, you have to look at it. So this leading to this kind of a situation, the tilt which is there, it is becoming static due to the situation is there. So this is what we need to. Another line which is taken as important is this line between anterior spherical spine and pubic symphysis. This is a anterior-posterior plane of the anterior plane of the pelvis. In routine, in a flexible spine, it is always straight. We all from our anatomy knowledge that the both are likely to be in the same line, the pubic symphysis and anterior spherical spine. If you have got a axillary little tilted also, you can have the center of the two ASIS and have a center from that becomes the straight line. What happens? It could be tilted back or it could be tilted in front. Here it is tilted into the front from the neutral line, from the vertical line. This is 8 degree. This is tilted backwards. Here it is tilted backwards from the front. So you can see this is a different way. If this is again with the normal range, it may not affect the placement of the cup. But if there has been a deformity, this is not my X-ray, here there has been a deformity, it could be a significant change. And when that is a significant change, it might affect the movement. Now, there are many lines drawn around the spinal pelvis. I am just picking the essential ones only. This is the another line which is supposed to be pelvic incidence. This is a line along the sacrum from the center of the sacrum and one towards the hip joint center. This is constant 55, whatever is the position. This, whether sitting or standing, it remains somewhere. That is a fixed, it doesn't move. Another thing is, you can see the same example in this area also and this area also. This angle remains same whether we are sitting or standing. Another important thing is now the lumbar spine, how flexible it is. So what is the level of the lumbar lordosis happening? And this is the line between two axes. The angle could be this way or it could be this way. This is the lumbar lordosis level. Why I am talking about these two things is, if the difference between pelvic incidence and lumbar lordosis is more than 10 degree, it is a sagittal deformity of the spine. Another very important factor. So we could have a normal spine, we could have a flexible spine, or a stiff spine, or we could have that flat back deformity where the anterior line is going posteriorly. Is it common? This is the data of prevalence of sagittal spine. 60% will be normal, 16% will have flat back, 25% will be hyperlordotic. So it is not uncommon. And what it can do, it can make our so-called safe zone unsafe if we put the cup in that very position. So it is a beautiful classification, easy to understand. I have reduced it to this classification. Understand, either it is normal or there is a spinal deformity. Spinal deformity, it has two further factors, normal spinal mobility and stiff spine. So either it is one with A, normal with normal spinal mobility, meaning by normal, there could be a normal with stiff spine, one. There could be spinal deformity with a normal mobility and a spinal deformity with a stiff spine, and these are the conditions. So this is a beautiful classification which has been given, and this is the kind of a management given. If it is 1A standard, it is 1B when there is a stuck standing normal element but spine is stiff, you change a bit. And if it is a flat back deformity, the deformity is there but mobility is there, again you are normal. And if it is a flat back deformity, depending upon which way, you will have to alter the position of the cup. So, and how this can be achieved? You are a good surgeon, you do a good planning, you can do an excellent workup with your technique, or believe in what the company is putting up here, you can have a robotics for that. So my message is, when performing, I am adding to what Professor Sudhir told, standardized evaluation of hip and spine also, and pick up those patients who have either a stiff spine or a deformity of the sagittal axis, and if that is there, redefine your positioning of the cup. Here safe zone, so-called described, is not safe, alteration might have to be done. Thank you.
Do you think that such much high anterior approach that predisposed to instability in these cases?
The anterior approach is meant to take care of the capsular problem. Cup positioning will still be abnormal. So that is no remedy for this thing. That's no remedy. Cup position is a cup positioning. It might give you a little more liberty, obviously so, but then you cannot really feel foolproof in all those things. So it's better to be careful about stiffness and the flexibility of the spine.
So can we add a little
Please.
bit more to this? So our understanding, and correct me if I'm wrong, one is that you are normal. Spine moves well, you can forget about those patients.
Yes.
Whatever is in the hip, you go ahead and do it. One is they are stiff, but they are still in normal alignment, like normal lordosis. So again, you can more or less ignore them. One would be hyperlordotic. So those patients, you need to dial in more anteversion. And the ones which are like stiff back in the kyphotic, then those ones you need to dial in a bit more anteversion. And the amount you can dial is only about 10 degrees.
Yes.
Not more than that.
Yes, that's the only thing. But we have to know about it and we have to do that kind of a dialing. Is that okay? Thank you. Thank you, everybody.
Thanks a lot, sir, for this elegant presentation. And in fact, you will get the another chance of hearing this elegant voice with another live surgery performance by Dr. Ramesh Sen as the 4th live surgery workshop on total hip replacements. Next, may I request Dr. Sanjeev to be on the dais, please. He'll be speaking on anterior approach. Dr. Sanjeev, please. Can you welcome with a round of applause?
Good afternoon. So my talk is on anterior approach to the hip. So can I ask from the audience if anybody does the anterior approach to the hip? Because traditionally hip replacement involves incision on the side of the hip, which is a lateral approach, or on the back of the hip, which is the posterior approach. And most of us are trained to do either of the two approaches. So direct anterior approach was first described by Carl Hutter in 1881 and then was propagated further in 1990 and 80s by Smith and Peterson. And with the special table for arthroplasty, direct anterior approach was popularized by Joel Marta. The principles and basic techniques of the approach are the same, whether we use a specialized table or not. So indications are many. So the hip, any pathology for the hip can be managed by direct anterior approach. So surgical approach involves positioning supine on the table, standard table. We can or cannot use the specialized table depending on the experience of the surgeon. And sterile field is up to the xiphoid process to the entirety of the lower limb. A standard approach involves an incision approximately 7 to 10 centimeters, 2 centimeters below and lateral to the anterior spherical spine, and goes down up to the lateral epicondyle, in the direction of the lateral epicondyle. So superficial dissection is mainly concerned about prevention of injury to the lateral cutaneous nerve of the thigh. So incision is made over the TFL and musculature is dissected of the medial fascia bluntly, and retractors placed around the superior aspect of the neck of the femur. The deeper dissection involves fascia overlying the rectus femoris is opened and bluntly expose the anterior capsule, and the retractor is introduced on the medial aspect of the femoral neck outside the hip joint. We incise the hip joint capsule in a longitudinal or a T-shaped incision, and this exposes the femoral head and neck. The hip is dislocated by traction and external rotation, and the acetabulum is very well visualized now, and the procedure on the acetabulum part is carried out. The approach can also be extended down distally on the lateral aspect of the femur by either releasing the vastus lateralis from the origin or bluntly dissecting it. There is a problem with regard to the femoral component because it goes down and it needs special retractors to be lifted up. So wound is closed in layers and care taken to close the lateral femoral injury to lateral femoral cutaneous nerve. Advantages of this approach are it's a rapid recovery of the patient, lesser hospitalization, lesser pain in the immediate post-operative period because we are not cutting any muscles, unlike the posterior and lateral approach, and more normal gait biomechanics, less soft tissue damage, more stable hip, no need for hip precautions as we do in the usual posterior and lateral approach, and access to the iliac crest in case we need to take a bone graft. So disadvantages are, it's a learning curve. A lot of studies which say that a lot of complications in the initial 100 surgeries by most of the surgeons. The injury to lateral cutaneous nerve, risk of fractures of the greater trochanter or of the femur, and we need specialized instrumentation to have access to the femur. So in conclusion, it's a minimally invasive surgical technique which involves a small incision on the front of the hip, involves less injury to the muscles along the natural tissue planes without injury to the tendons. There is a quicker recovery, less pain, and more normal function. Hip precautions are not necessary. It allows patients to return to normal shortly after surgery with a reduced risk of dislocation. So this small video.
So, 4 centimeter incision from the anterior superior iliac spine, 2 centimeters distal, 2 centimeters lateral. Superficial dissection between the intramuscular interval of the sartorius and the tensor fasciae lata. Exposure of the femoral neck, resection of the capsule, exposure of the acetabulum, preparation of the acetabulum so the tight cortical fit is achieved with the appropriate reamers, compaction of the appropriate size acetabular component followed by the polyethylene bearing, exposure of the femur, resection of the superior capsule to allow for delivery of the femur, sequential broaching until a tight cortical fit is achieved. With the trial, femoral head reduction, confirming absolute stability through a full range of motion as well as equal leg lengths, removal of the trial, compaction of the real femoral component, followed by the real femoral head, reduction of the hip, confirmation of stability and leg lengths, and then closure.
So in my opinion, it's a good approach to know about, but we should stick to the traditional approaches that we are used to, which is the anterolateral approach or the posterior approach. Thank you.
Sir, I just wanted to know if there is any specific indication for anterior approach, or is it just a surgeon preference?
If we're talking about the hip replacement, I think most of the surgeons are trained in anterolateral approach or the posterior approach. Only some of the surgeons that I'm aware who want to venture into something new and something different are going into the anterior approach. It leads lot of, it's a slow learning curve, a lot of specialized instrumentations are required, and indications, there are hardly any. I think maybe one indication that I can think of is when the acetabulum has been fixed anteriorly, fracture of the acetabulum, and you want to do the replacement. So that is one indication where we can use this approach. But even that can be done by the standard anterolateral approach.
Is there any advantage in the ankylosed hip
or with patient with AS if we do anterior approach as
No.
compared to posterior?
I think access to the posterior part is less. Of the acetabulum is less.
Sir, the stability with the spine component, stiff spine component, will have more stability as compared to the posterior approach.
Again, as Dr. Sen and Dr. Sudhir gave the planning, if the planning is good, with the standard approaches are good enough.
Thank you, sir. Thank you.
Thank you.
Thanks a lot, Dr. Sanjeev. After that, we have the presentation from Dr. Abdul Ghani. He has come all the way from Jammu with us. Have a grand Punjabi applause for him.
Bearing surface. ये वाला टॉप वाला Very good afternoon to one and all. At the outset, many thanks to Dr. Shubhang Agarwal and his team, and many congratulations for organizing such a wonderful show. My topic is bearing surface in THR. So at the outset, what is the background, why the topic is needed anyways? When we are talking bearing surface, essentially we are talking of the articulation between the femoral head and the cup liner, and what exactly the surface should be. Actually, there is ever-changing trend. Ideally speaking, the arthroplasty should last forever. I mean, as it should last with the life of the patient, but it does not happen. One of the reasons is because of the bearing surface, because it can lead to wear, and wear particles are one of the cause of aseptic loosening, osteolysis, and that leads to need of revision in the future. Because especially when you are talking about young patient, if you do a THR, their activities are high, the wear rate is going to be more, and hence there is a need of revision. So that is the reason there is a talk about the bearing surface. Although the THR, the total joint replacement, has been a successful and wonderful surgery, but there are essentially the failure rate, especially in the young patient, and one of the reasons is the choice of the bearing surface. If you take this slide, on this left top, there is a metal and poly, then you got metal and metal, you got ceramic and poly, and ceramic and ceramic. So why has to be variation? Why these controversies anyways? Because there are limited long-term studies of the good bearing surface. Lack of long-term follow-up. It is mainly experience-based and at times maybe evidence-based. There are lack of RCTs with direct comparison. Ideally speaking, it should take 20 to 30 years to have a good result outcome. Then only you can decide. And in mid-term, however, there are similar outcome more or less with all the bearing surfaces. So what is ideal bearing surface, and do we have that? The ideal bearing surface should have a low coefficient of friction. It should not have any wear particle generation, no tissue reaction. It should be biocompatible. It should have a high resistance to the third body wear, and it should have enough of deformation of article surface to permit adequate fluid film lubrication, and of course it should be affordable so far as cost is concerned. When we talk of bearing surface, there are two major classifications: hard and hard bearing and hard and soft. When we talk of hard and hard, we are talking metal and metal or ceramic and ceramic, and we are talking soft, hard and soft, metal and poly or ceramic and poly. This is example on the left side is metal and poly, metal and metal, and an extreme right ceramic, and in between ceramic and poly and ceramic, metal and poly. So what are there are advantages and disadvantages. The main disadvantages when we talk of metal and poly actually get divided into two types, traditional poly and highly cross-linked poly. And there is invariably some disadvantage with each. With the traditional poly, there is more wear and osteolysis, whereas even with highly cross-linked poly, there is a decreased mechanical strength. And when we talk of ceramic and ceramic, there is a part of problem is breaking and squeaking. And metal is going to lead to more high level of iron, osteolysis, pseudotumor formation, and other stuff. I mean, this is a picture, huge metallosis and wear, and that leads to early loosening, early revision, and lot of metallosis intraoperative. This is another example of chip fracture of both the head as well as the liner, and this is oxynium head, which is another type of bearing surface. The potential advantage of metal and metal was actually we could use larger femoral head, and that is going to lead to better range of motion. It is going to be more stable, it will increase the range of motion and decrease articular pressure. With the decreasing head size, one can have a less wear, reduce friction, but it is going to be more unstable. But unfortunately with metal and metal, there are a lot of metallosis, pseudotumor, alveolar lesions, and there are potentially theoretically chances of high generation of ions, cobalt, chromium, which can lead to systemic toxicity in the form of cardiotoxicity, neurological damage, ocular toxicity, nephrotoxicity, and even potential malignancy as well. Hence, it has almost been abandoned now by surgeons and withdrawn by the manufacturer as well. Then the next line bearing surface is poly, essentially more or less called as polyplastic, and traditionally it used to be polytetrafluoroethylene. That was started by John Charney, and actually he inserted in his own thigh just to test whether what is the tissue reaction going to be there. But again, the traditional poly had major two disadvantages: high wear rate, and there is a lot of amorphous material. Then came high molecular weight polyethylene, and the latest is highly cross-linked poly, which is now available, and more or less all the companies, they are making this type of poly, which essentially is made up of more cross-linking. It is treated by heat treatment, and it is sterilized, avoiding any oxidation or exposure to air. Because this has got 86% less wear compared to the traditional poly. And latest is addition of vitamin E, because vitamin E is antioxidant, and because it reduces the exposures of the free radical and increases the wear resistance. It has got also the advantage that various offsets can be available, whereas with the traditional, with the ceramic, you do not have that option. Head sizes also, you can have variable head sizes, you can have elevated lips, and at times you may have to change the liner face. Nowadays, the latest is ceramic, which is more commonly used, particularly in younger patients, and it started though in 1970, and there is a lot of improvement so far as the composition is concerned, and now we've got 4th generation of ceramic available, and that is mainly comprises of 82% of alumina and 17% of zirconia. And in Australian registry, there's a 92.8% survival of THR in young patient at 15 years. What is the advantage of ceramic and ceramic? This is hard, this is hydrophilic, inert, it is resistant to any scratch, it has got high biocompatibility, the wear is independent of the size of the femoral head. So that is obviously, this makes this particular bearing surface to last longer. And that is what the requirement, particularly when you are talking of young patient. However, it does have disadvantage. This is also not immune to complication. It has got a risk of fracture, both of head as well as the liner. And the squeaking, whenever the patient walks, there will be a particular noise, and that can be irritating. Of course, it's more costlier as well. Particularly the risk factor for the fracture is if there is this does not tolerate too much of malalignment, and especially version more than 25 degrees do not tolerate if there is any abnormal version. So you have to have a perfect alignment so far as the insertion of implant is concerned. Your technique has to be better. This is an example of breakage of the implant, ceramic implant. This should be avoided in extreme cases of excessive deformity, particularly severe DDH, or in excessive laxity. If the patient has got excessive laxity, more range of motion, again, even in younger patient, it should be avoided. There is also change in the version of the ceramic, and delta ceramic is more available, and it has got 97% more tougher. However, the rate of ceramic fracture is much less with the latest ceramic delta type, whereas the head diameter If it increases, the chances of liner fracture is going to be increases. You can also have another combination, ceramic and poly, and this has got obviously low wear rate and no squeaking and no fracture. Another bearing is oxynium. Again, the results are not as good as was projected initially. Ceramic and ceramic THA is correlated with better 10 years outcome. When it comes to the ceramic and ceramic bare surface, another study, lower rate of revision, osteolysis, radiolucency and aseptic loosening or dislocation compared to metal and poly. In New Zealand registry, the best combination, best bearing surface is ceramic and poly, even in the younger patient. This is a study from America in pediatric THR. Again, previously they used to do ceramic and now they have come out to ceramic and poly. Effect of the bearing surface does have a bearing on outcome and longevity in NGR in UK registered. In conclusion, long-term survival and satisfaction of patient is linked to the proper bearing surface selection. Not all polys are same, not all ceramic are same, they have got a different make. These features differ from one brand to another. Implantation tool can make a great difference. Ceramic in young and active patient, and ceramic and poly, highly cross-linked poly and metal and poly are valid option. What actually makes the difference is not just the material, but the correct surgical handling and the technique of the component, especially mainly the positioning of the implant. Thank you very much. Thank you.
Very good afternoon, sir. I'll just ask you, what is your personal opinion in young patients, whether you like to do a ceramic on poly or a metal on poly or a ceramic on ceramic, sir?
In younger patient, personally, I would choose ceramic and poly. Reason it's slightly more forgiving. Cost-wise also it's slightly more balancing. So that is what it is.
Any personal experience with ceramic on ceramic squeaking or noise that the patient is complaining, something like that, sir?
Not much. Thank you. Thank you.
We are again having this company coming with oxynium and oxynium.
Yeah.
They're coming back. So after having metal on metal, again we are switching back to oxynium and oxynium.
I mean, we have to wait for the long-term studies, as I told you. Ideally speaking, it takes 20 to 30 years for comparative study or cities. Then only we will be able to conclude, actually. But there is a industry is going to evolve, of course. They will keep changing and becoming better day by day. Thank you.
Thank you, sir. Thank you.
Thanks a lot, Dr. Abdul Ghani. Can we have the next speaker on the dais, please? Dr. Rajneesh Garg. He'll be speaking on extended trochanteric osteotomy. Can we have a warm round of applause for welcoming him?
Thank you. Good evening, ladies and gentlemen. At the outside, I would like to congratulate Dr. Shubhang for organizing such a wonderful and informative conference workshop. So we really had, we enjoyed 2 or 3 live surgeries in the morning. So my topic of discussion today is extended trochanteric osteotomy, ETO. So I'll start with the case. So case 1, 61 years old female patients, hemiarthroplasty done few months back somewhere outside, presented with the severe pain and movements, painful movements. All the movements are restricted. There was a history of, in this patient, there was a history of discharging sinus and debridement by the primary surgeon. So ES and CRP was high. So it says cemented hemiarth. Similarly, another patient, again, almost similar complaints, hemiarthroplasty done just a few months back only. I think it was done in Jalandhar only. So patient was, again, had inability to bear weight and ES and CRP was high. And this was quite painful. So both the hemis probably, they both are infected, right? So what is the problem? How would you proceed with the surgery? What do you think?
Sir, kindly go back to the case 2.
Cemented hemiarthroplasty, 70 years old female. Now she has presented with a severe pain, fever,
ESR CRP is high. So we had diagnosed TLC was high, it is infected hemiarthroplasty. So the plan is to actually remove the hemi and the cement. So what we are going to discuss here is that how you plan to proceed with the surgery, what are the problems you are anticipating in this case, how much time you think that it would take, blood loss, single stage or a double stage surgery, what is the prognosis and anticipated complications during and after the surgery. So like we have seen earlier talks also by Dr. Sudhir Garg also, that we have to plan all this. We have to keep all these things in mind. So what are the things you have to keep while removing this component? So first of all, it is difficult to remove the well-fixed component itself, right? And then you have to remove the cement. You have to plan that how will you remove the cement, how much time you are going to take, blood loss, you have to prepare for the this blood also, and single stage or double stage. So most of us would definitely agree that we would like to, since it is potentially infected cases, so we would like to go for a 2-stage. First, we will plan for a removal of the implant and the cement, and second, we do some secondary surgery. So this hemiarthroplasty or total hip replacements, they are quite successful procedures. But in spite of all these success stories, we do have some problems where we face the failure and they need revision. But this revision surgery is going to be quite challenging in terms of the labor, time consuming, lots of complications, and has a guarded prognosis. So one of the most challenging aspect of this revision surgery is going to be the removal of the well-fixed femoral component and removal of the cement. Choice of the procedure in this case would be ETO. So ETO, this is starting from the greater trochanter and almost minimum 12 centimeters the trochanter along with the lateral diaphysis of the cortex to the variable length is ostomized to expose the femoral canal. Earlier in 1981, way back, was the first one to describe the trans-trochanteric approach to the native hip. But it was mainly popularized by the Sir John Charley in 1960s. So he advocated trochanteric osteotomy in all the patients, primary as well as the revision cases. But he also had the non-union rate of 4.2% and other complications. So this was a study published in 1972. But what are the problems with trochanteric osteotomy? In the hands of even great Sir John Charley, it was about 5%, but normally the non-union rate is almost up to 10 to 15%, 9 to 18% chances of non-union. Then we have increased dislocation rates, proximal migration of osteotomy, Trendelenburg gait, and reduced patient satisfaction. So these are all problems with the, so there were then certain improvements. Glassman et al., he described trochanteric slide osteotomy to remove certain complications. Similarly, Wagner et al., 1999, transfemoral osteotomy. But ETO, it was 1995. It was first described by Younger et al. It was basically used by Peprosky in his revision cases, which he again published a paper in 1995 in Journal of Arthroplasty. What are the indications? The first and foremost indication is to remove a well-fixed, cemented or uncemented component. So if this component is very well fixed, what if we try to just pull it just like that only, or do lot of apply lot of force there? So what do you expect? The high chances of accidental fracture of the femur, perforation of the femur, and sometimes, especially in the case of both cemented also, but especially in case of uncemented, there can be a significant loss of bone stock. But ETO will allow a controlled removal of component in this scenario. Similarly, a well-fixed cement mantle in both septic and aseptic cases. This is one of the most challenging and time-consuming step. If you just try to remove the cement without ETO from a tube, it is very, very difficult to, believe me, remove the cement. Septic cases, if there is a certain level of quantity of leftover cement is there, still there, it will be always source of a reoccurrence of infection. So if we do ETO, it will allow us to do a thorough debridement and removal of the whole mantle of cement under direct vision. Similarly, in aseptic cases, if there is a leftover cement, what will happen? There are cement pieces there, it will, there will be undersizing of the stem, thereby subsidence. And also this components of the cement, they will put the, will put the, this stem in a malpositioned place. And there will be, since there is a cement, leftover cement is there will be lack of osseointegration in the cementless component which we are going to put. So this is a study which was published by Lurch et al. In non-ATO groups, there was 14% patients had a accidental femoral fractures and perforation, whereas no such complications was observed in ATO group. And even clinical and radiological outcomes were superior in ATO group because we were able to remove whole of the cement and there was no infected component of the cement which was left in the canal. Similarly, another study, Perk et al. Published in 2007. So almost similar views that stem subsidence, cortical perforation, complications, they were all less with the ATO. Another study published by in 2011, Journal of Arthroplasty, by Lim et al. So osteotomy along with the removal and debridement and temporary cement spacer insertion was done in 23 cases. 100% union rate of this ETO, the osteotomy at the second stage. So this is very, very important that if it is a well done osteotomy, you will be able to get 100% rate of the union. And there was a successful eradication of the infection in 96% of the cases. Another study by Purty et al., Journal of Arthroplasty again, 2017. Similar results, 100% union rate, no case of perforation or accidental fracture, infection eradicated in more than 90% cases, and especially in this study, they had seen that in how many cases they were able to put a primary standard processes, not a revision processes, and 70% of the cases they were able to use the standard processes during the second stage. So this is so many advantages of extended trochanteric osteotomy. So what are the other indications? We talked about the revision cases, but what are the other indications? There are certain other indications also. So in certain, you see that there is a erosion, protrusio of the acetabular. So this is like this head of the process, it gets logged in the acetabulum. So sometimes it is very, very difficult to actually dislocate this head. Okay, difficult to remove this head, to mobilize this head. So ETO can be really come handy in these situations. So this is an example. So ETO was done and this stem was removed very nicely without any complications. So sometimes there is a varus deformity in revision cases. So you can do ETO and you can put a revision processes. Similarly, you can adjust the tensions of the abductor mechanism. You can also use it in a periprosthetic fractures, Vancouver type 2 and 3. So as compared to Chanley, who used trochanteric osteotomy for all cases, nowadays we are recommending ETO for a complex primary cases like we have just seen, femoral deformities, high congenital dislocations, or the revision cases. The approach, mostly used approach is the direct lateral or posterior lateral approach, though the posterior lateral approach is most commonly used. The mainstay of this, the success of this surgery will depend upon the vascularity and soft tissue attachment of the osteotomized fragment. So in all cases, by any thing, you have to preserve the vascularity and soft tissue attachments. So surgical technique, position of the patient, cleaned and draped. So this is one very important aspect, surface marking, extent of the osteotomy. So this you have to really plan pre-operatively. Many of us would get confused. Just 2 minutes, please. Last slides, 2-3 slides. So many of us would get confused the extent of the surgery. So we will do at one level, then it will not, the bone plug or the distal cement will not come out, then we'll again go back and again do a osteotomy. So you have to plan that well in advance, that what should be your plan. It will depend a lot on the quality of the bone, the isthmus, everything. So I'll just skip, this is the exposure, and I'll just go to the video last. So this is video. This case only, just operated last week only. There were 2 cases, so which we operated last and did the ATO. So this, since it is a polished stem, the removal of stem is very easy in this case. But in cemented case, or if it is a well-fixed stem, sometimes it is very difficult. So you can do osteotomy with stem in situ, or with after the removal of the stem, like we have done in this case. It is slightly easier when you have removed the stem. So now this is how, from posterior to anterior, you start with the posterior, just anterior to linea aspera, and all the soft tissue you see, the attachments are preserved, very well preserved. So you drill the holes from posterior to anterior. So you prepare it for the osteotomy. And then you have to do the transverse cut also, where anterior and posterior holes are meeting with each other. And then with the saw, you cut the posterior cortex like this. So anterior cortex, either you can weaken with the saw only, or you cut it with complete the osteotomy with the osteotomes. But most important aspect in this surgery is to preserve the soft tissues and the vascularity, and prevent the complications like any injury to the neurovascular bundle. Sciatic nerve is there on the posterior side, femoral artery is there on the anterior side, so you have to be very, very careful. So once the osteotomy is complete, so this is the transverse leg of the osteotomy. This is again very important aspect. So you complete this step without any stress rises. So then complete it with the osteotomes like this. It should be anterior 1/3 of the cortex which should be removed, okay? Not through and through, half and half. It should be, and then now you can see the cement directly, and with the cement removal instruments, very carefully you can directly see in the canal, and you can remove whole of the cement. And since, as we had discussed, it was an infected case, we had to do a thorough debridement and remove the whole cements, that there is no infected material is left in the canal. So once everything is right in front of you, so you can remove and debride under direct vision. So this is the post-operative X-ray, and then this is the another very important, this thing is the distal prophylactic encerclage wire. So it is very, very important to put a distal prophylactic encerclage wire distal to the osteotomy. Minor and at all, they found that even all the patients, in 15% of the patients, 10 to 15% of patients, they are always undisplaced cracks which are extending from the level of osteotomy to the distal end. So if you will put in you do the reaming, or you try to put an uncemented stem, it will open up. So it is always better you put in a prophylactic cable there. Method of fixations. Various cadaveric and non-cadaveric studies have shown that 2 to 3 cables are sufficient, and then steel cables are better than the steel wires. In case of steel wires, there is a 10% non-union rate, but in case of cables, it was 100% because of the uniformity of the compression, but they are slightly costly. So if you want to save costs, so you can use the steel wires, otherwise cables would be better. Method of fixation. So this is case 1, post-op. Antibiotic beads have been put. Case 2, which we have just seen the video of it, and again, and then they are waiting for they would go for the second stage surgery. So in conclusion, so it is basically reserved for the either revision cases or a complex primary cases. We have a direct access to the femoral canal. We can remove the cement, we can remove the component, we can remove the infected material from there, thorough debridement under direct inspection. If we completely remove the cement, we can put in a better Pacific uncemented stem. It will not be undersized, it will not be malpositioned, and minimal chances of fracture and perforation. It is less time consuming, less chances of subsidence and loosening. Union rates are 95 to 100%. And promotes induction of bone healing and ingrowth in revision with uncemented cement. Thank you very much. Any questions?
Sir, very good evening. Sir, I want to ask, like in case of aseptic revisions, in case you have a patient with a cemented stem, you have a loose stem, you take out the stem, you definitely go for a ETO, or you try to remove the cement with the flexible osteotomes?
See, you can try, if you can pull this whole mantle with something, if it is, you can preoperatively, you can see that a whole mantle is lying separately, which is very rare, okay? It is only possible sometimes in a septic cases or in a very osteoporotic bone. In those cases also, chances of complications are very high because the bone, quality of bone is very poor, bones are osteoporotic. So I've seen, and earlier I also used to try, so I've seen many patients, it takes 2 hours, the whole procedure, otherwise it is 45 minutes or 30 minutes. The cement removal, it takes 2 to 3 hours. The time is blood, and patient is going into shock and having so many other complications just because we are trying to remove the cement from the tube, which is very, very difficult, very cumbersome, and it is always inadequate. And then sometimes even I was able to remove the cement from proximal side, but I was unable to remove the cement from distal side and the bone plug. Again, I had to go for a osteotomy after struggling for 2 hours.
You can do cement in cement technique.
That is yes, cement. That's why I was told you that if you are going for a uncemented implant, or if the cement is infected. If it is aseptic technique and you are planning for cement and cement, then it is okay.
Sir, you mentioned, sir, that extended trochanteric osteotomy can also be included in very complex primary cases also, and not
Yes,
only.
there are few examples.
Yes, sir. Can you please elaborate on that, sir?
Yeah, few complex cases like I showed you, there's a locking of head in the acetabular. So there's a fibrosis, lot of fibrosis. It is really very, very difficult to mobilize the head, and this you cannot do in normal cases. So we can cut with a saw. The head sometimes we cut in situ only. Here you cannot do that also. You do ETO and remove the whole stem from distally. Or complex primary cases like there's a bowing of the femur. There actually the primary stem will not go because it's straight. So the chances of perforation or the fracture or high dislocation, congenital high dislocations. So these difficult primary cases where you need more exposure of the acetabulum. So you think that the acetabular exposure needs to be enhanced. In those cases, you can primarily go for ETO. But not every case. As we just discussed, Chanle used to do trochanteric osteotomy maybe in the beginning of his series in all the cases. But it has its limitations, so you should try to avoid in all the cases.
Thank you, Dr. Jagdish, for excellent talk.
Thank you. Thank you, sir. Thank you, sir.
Thank you, sir. Thanks a lot. My apologies for the next speaker. In fact, we have a call from that force surgery live session that the patient is ready. We are just going to operate. We have to pause for a while, sir. Kindly excuse us for that. Can we have the live surgery relay for the force surgery? That is by Dr. Ramesh Sen, dual mobility total hip replacement. My apologies, Dr. Rajesh Kapila. Kindly bear with us for a while.
Hello.
Yeah. We are able to hear you, sir. We are just having the dais, the moderators. Kindly give us a minute, sir. So for this live surgery, may I request the moderators of this session, Dr. Rajesh Kapila, Dr. Abdul Ghani, Dr. Neeraj Bansal, and Major Parduman. Kindly grace your presence. So grace the dais with your presence, sir.
Dr. Sen, good evening. So we are ready here for you. The X-ray is being seen on the screen.
Okay, so am I audible right now? Hello?
Yes, sir, you are audible. Very much audible, sir.
That's great. So I'm going to the X-rays and let's evaluate the X-ray. If I have a point, some kind of a pointer, can you give me some wire or pointer? Yes, artery here. So, is my artery visible?
Yes, sir. Yes, sir. Yes, sir.
Okay, so now I am concerned, is that X-ray visible?
Yes, sir. It is visible.
So, yeah, so the important thing here right now, we are able to see it, little tilt in the pelvis, then we coming down to the hip. This is the normal side hip, and this is the affected hip, which we are likely to operate right now. And here, if you notice it down, the overall external background is not very clear, it's all fluffy around. The femur head may be little visible around here, but definitely the intensity is not very good. Then we come down to the lesser trochanter as compared to the normal side. It has migrated up, neck is quite short over there, and it is also muffled in between, not very clear now. Overall, there is no inlet increase or an outlet increase, so we do not feel there is any lateral deformity right now. Here there is little rotational deformity which is visible, but otherwise it's not there. So the hip is relatively stiff, so we don't have much of the movement around this hip. Here what we are looking for is an offset which is a very standard offset for a hip joint. So we'll have to reconstruct the same offset. We have about a centimeter of shortening here which might manifest as a 1.5 centimeter in the real position. So we are looking for a hip shortened by 1.5 centimeter and with very short neck and a kind of mistake. So we can now shift over to the from the CT scan. Is that okay?
Yes, sir.
So when we come over to the CT scan, as we go from up down to the level of the joint, we are able to see here lot of osteophytosis anteriorly. And this has changed our perspective of the hip because it looks very much retroverted right now. Lot of osteophytosis here in these images. I don't know how magnified they look at here because I don't have any idea about how you are looking at these X-rays, this CT scan. But there is a significant retrovertal, so basic thing is we will have to do lot of osteophytization of this anterior osteophytosis. So there is a lot of it. Rest of the walls are okay. The head definitely is necrotic over there, and this is what we have got in stock. As the superior part is relatively altered over there, but we still are able to feel the anterior and the posterior wall. So any specific query about the CT scan? And if no, then I am going to the patient. So here, am I okay at the table?
Sir, excuse me, sir, what is the age of the patient?
It's 40 years.
40 years. So then what is the specific indication of dual mobility? If you can clarify a little bit.
Right now you know what is the indication of dual mobility, is introduction of dual mobility as that. It is a stiffer spine, we expect everything to be stiffer. So technically speaking, we do not have any specific point to make it dual mobility specific. The procedure we are doing this because this is a demonstration. This is a first dual mobility surgery for this particular implant, Smith and Nephew.
Yes.
So in India.
In India, it's the first dual mobility from Smith and Nephew which is coming out. So if that can be indication, then this is the indication. Okay. So right now this is the proximal side, this is distal, this side the front side and the back side, this is our marking. And here we have what is that light okay with it because we have decreased the light from the area. So inside we don't know how much the visibility because if we bring the light directly then it becomes totally whitened out. So is that okay right now?
The light is okay, but the camera is moving very fast. Now it's fine. Yeah.
Okay, that camera is still not clear.
Yeah.
So then it's still moving, I am not sure. Because I am looking at the image which is from the...
Little bit more focus can be done. A little bit
Can you
more.
focus it out? Because incidentally I am not able to see what you are seeing.
Okay.
So I cannot comment about that. Because that camera has only output down there to the hall. And in between, let me tell you, we have got our very well tailored team. Anesthetist is also our anesthetist for last 3 years back. So she was with us, Dr. Harleen here, with me in Nhs Hospital. Rest of the team, my people, Dr. Gaurav, Dr. Himanshu and Sandeep and Devinder, they are all with me here. So I am relatively more comfortable than the people who operated upon them in the morning. So can I start the surgery?
Sure, sir.
Please do, sir.
Please do, sir.
Time out. So here is the greater trochanter, we are able to see, we have marked it out. So I am giving little bigger incision than the routine because of, so that I could be little clear in my demonstration. Can you give me a forceps?
There is no need of picture in picture, so can we remove that? Only single view is good enough, I guess.
Can we remove that is for the intermediate people to listen?
So that image is actually for the other camera. So whichever you can see better, you can zoom in. So that's on, one camera is mounted on the light, one is in the hand of the cameraman.
So are you using modified Gibson's or posterior Cochran? Are you using the approach?
Standard posterior approach, and very classical kind of approach. Here you can see this is the greater trochanter, this is the lateralis, and here we have got the gluteus. Here you can see it out. The medius, the maximus is already out, and here the fascia is taken out. You can see the interval between the medius, and down there you are able to see the piriformis here. So I am picking up the piriformis. Can you just make it up? So if you can see it out, I don't know whether the light can show, but I am with the piriformis tendon here. This is a relatively a safe hip, so because we are compromising on the light, so we can you rotate it? Does it rotate? No, just try to rotate it if it's possible to rotate. So I am cutting the piriformis along with the capsule over here. I am sorry there is an aberration in the camera if it is there, because I do not know what you are being shown.